So you have studied Ayurvedic medicine, and these years take a major part of your life. Once you become a doctor, you are committed to healing. And to be a great healer, learning has to become a never-ending pursuit in your life. So doctor, what are you doing to continue this learning?
A very warm welcome to all the doctors, students and practitioners for this AACHAARA.
Learning experience for everybody, even for me also, isn't it? So there is no end for learning. So that's what actually I believe.
Today's subject you are given is psoriasis.
Clinical dermatology.
If you use Vamana on yourself first, then you will believe that it will help.
Spending few hours with a scholar is equivalent to months of time spent reading books. In the name of Acharya Rasayanam, we are bringing excellent minds on Ayurveda with rich expertise in clinical practice. The purpose of this initiative is to guide and uplift the confidence and clinical expertise of every Vaidya. There is a saying, if you cannot be a king, the next best thing is to become a healer, because you are changing people's life, and that is the power of a Vaidya. Acharya Rasayanam is a Ayurvedic practitioners only CME program initiated by Sitaram Ayurveda's 100th year celebration through Sitaram Research Foundation. Sitaram started its healing journey in the year of 1921. Being a pioneer in Ayurveda, Sitaram extends the healing powers through a state-of-art GMP certified manufacturing plant, government approved R&D laboratory, super specialty Ayurveda hospital, and an NABH accredited Panchakarma retreat. By attending Acharya Rasayanam, you will get the opportunity to get valuable insights on clinical practices, various methods and techniques prevalent in the Ayurvedic medical fraternity from the best scholars. You will be receiving the show notes, certificates, webinar recordings, and the latest updates on your email and WhatsApp. To receive latest updates and newsletters, please send a text to 89434 41881. For more details, log on to our website www.sitaramayurveda.com. Acharya Rasayanam. Great practitioners invest in learning.
Good morning, everyone, and a joyous Diwali to you all. On the special occasion of Diwali, we are gathered for the 154th episode of Acharya Rasayanam, a series of CME conducted by Sitaram Research Foundation and Sitaram Ayurveda Pharmacy Private Limited. Today, our topic is on pitfalls in spine-related orthopedics. Today, we have the eminent speaker, Dr. Shamir Thodengal, MD Ayurveda, Present Ayurveda, Orthopaedics and Sports Injury Specialty Clinic, Mankada, Malappuram. Welcome, sir. Welcome to Acharya Rasayanam. And today, our moderator is Dr. Srijit sir, MD Ayurveda, Senior Medical Officer, ISM Department, Kerala. Welcome, sir. And chair of the session, Dr. Ramanathan sir. Welcome, sir. And I welcome all the participants that are presenting here. Welcome, everyone. Thank you. Handing over to Srijit sir.
It's such a heartening feeling to have Dr. Shamir with us. Assalamu alaikum, Bhaijan. Welcome very much. It has been, I know Dr. Shamir is here in spite of a very special personal and spiritual reason. In spite of that, he's here. He has kind of obliged to come here. And I cannot thank him enough. And there are a few things that I would like to speak about Dr. Shamir and his work and how it can profit the entire audience. We know 391 enthusiastic participants have registered in spite of a Diwali, and all of us know this platform is pan-India, but it is majority from North India. But in spite of that, so it's nearly 400 enthusiasts are here, going to be here. So I thought it would be better I communicate that towards the mid, just before the product presentation situation, that may be an hour from here, because they are very, very important clinical aspects. But to justify the time of those who have already got into the process, I think it's important. Let us start with him. And one thing that is very special about Dr. Shamir Bhai is that even though he is a MD Dravyaguna background, his taste for ortho marma was so high. He got himself trained by the best of the best. One of them is somebody who was and is still very close to our heart and soul, Arshad Bhai. Arshad Bhai is no more. Dr. Arshad of Daisman Hospital is no more, but he still is lingering in our heart and soul. He was definitely kind of very close to Dr. Shamir professionally and personally, and Dr. Shamir was influenced by him before he started to make his own style of practice. And Shamir Bhai, please correct me if I use the word correctly. I think it's one Dr. Muhammad sir.
Yes.
Yeah. So anyway, I'll
Yes,
leave it to you to tell his full name, because we cannot thank enough. We don't have enough words to thank Dr. Muhammad sir. I don't know his full name, but I know he's near his clinic. And Shamir Bhai got extensively trained by Muhammad sir, in spite of all the drama the IMA people would be having against him, and whatever intimidation those people would have, that why an Ayurvedic fellow is being treated so well and taught so well by an allopathic, famous surgeon or whatever. So we are so grateful to that great soul, Dr. Muhammad sir. For the details, Shamir Bhai would say anyway, that helped him to enhance his clinical acumen. He was already a brilliant student and brilliant physician in that sense, but he upscaled and upscaled and upscaled. I think this is very important point we should comment about him, and it's a very what we call as a important inspirational point, that somebody from a so-called non-clinical department, and I know there are areas where people do raise their eyebrows, how he is so efficiently able to do it. And I would be telling this point once again. Dr. Ishmi, is it okay after 1 hour you get the handover after 1 hour, so that
It's
our faculty gets a voice break of 5 minutes, and then I would use these words again, is that I know him personally for almost now 4 years kind of scenario. And what is so great about him, and I will repeat it after 1 hour again, that when you send a doubt or a request or a clarification or a margin guidance, he is so humble and magnanimous that he calls you and tells you. I mean, that is just out of our service. Like, it's just so big of him. And I don't say that we should expect every time from him, given the schedule he is very tight, like all of us are. But that is his greatness at a personal front. Apart from the professional clarity he has, is just amazing. Maybe it's because he had a very clear Ayurvedic training or understanding and everything very fantastically. That is one. And secondly, also because he knew and he knows the limits and possibilities of the allopathic section and the Ayurvedic section. Shamir Bhai, please correct me if I am making any wrong statement. You just have to cut me then and there. I'm not qualified to be your moderator, but officially I'm your moderator. I'm not qualified for that. So I thought we should have the right kind of a narrative and understanding given to our audience, because there is a purpose. And I knew very well, Shamir Bhai has a very special spiritual and personal engagement today, but in spite of you obliged, but I want to have a Diwali dhamaka for our audience to have a very special topic and a very inspirational personality on Diwali day. So he would lead us in the most, what we say, competitively efficient, effective, and the best outcome oriented guidance. Because as Ayurvedic doctors, we are bound, like as otherwise also as normal human beings or normal professionals, we are bound to give the best to any patient who comes to us than remaining Ayurvedic militants. I use the word Ayurvedic militants. I won't use the word Ayurvedic patriots. I use the word militants. There's a difference between patriot and being reasonable, and being a militant and being unreasonable, and just sidelining and not, we say Malayalam Bhagavakyade, like, and not considering the merits the other system very clearly has. So that happens many times, and I have seen, without naming any hospitals, even to the level of Ayurvedic colleges. And Dr. Ashmi, I will be repeating this again after 1 hour, because then we will have nearly 300 plus our participants there. There have been occasions where big hospitals, Ayurvedic government level colleges, not just clinic, not just hospital, college levels, where experiences of Dr. Shamir, which he learned from his mentors, really had a situation to give them some extra inputs. Again, we are not being in a position to tell anything to professors. That's not our intention. But they have undeniable experiences in the allopathy sector where they know at that point Ayurveda is best not done. The best thing that you can do somebody is to do no harm and to make sure that you direct to the best outcome oriented advice instead of being jingoistic about your own science. We need to have pride in our science, but we need to be realistic. This is exactly what Dr. Shamir would bring to us, so that we have a balanced approach of the best possibilities and limitations of allopathy. At the same time, what we call as the best of the Ayurvedic sector also. And Dr. Arshad Bhai, such a noble soul he was, such a great soul was. He's not with us. I will remember him time and again in this venue. He would have been so happy to see his, brother student like personality as a faculty here. And I think Dr. Shamir is also carrying the experiences from Daisman also. So basically, he had a lot of compromise made in his personal life to be so much trained. And we are getting everything like a piece of laddu and jalebi in front of us, just like a piece of cake. And you realize whichever groups you are commonly with him, the authoritatively correct, the honest, and the politeness and the magnanimity and the humility with which he communicates professional advices is just fantastic and great to learn, imbibe, and to propagate. So I think with this, let me hand over the most important part, which is typically I hand over by 10:45. But I think it's time enough. And then I will repeat these 2 points. And I was communicated 2 clinical points by Dr. Shamir to be communicated to the audience. But I will definitely, or rather, I will deliberately hold it back because it's best that we hear from him. And everyone can be very sure he's not being critical about anyone or anything or any institution. But I strongly believe there are 2 ways of being good. One is to be good, and second is to make others look bad. So we are not doing that here. We are definitely not doing that here. We are just telling what is the best practice. And this is an area where more people can get into. And of course, the phone number and the contact details of Dr. Shamir would be definitely shared with all of you. And as always requested, kindly put up your questions in the Q&A section. That will make it easier and quicker. We would not take anything from the chat. And by this, Shamir Bhai, we are all yours. And please bless us with your knowledge. We start with your Guru Parampara. We show our gratitude to them as much as we show to you. We are all yours. And you can quiz us if you wish. But I think it will be easier to just sail through it. So we are all yours. There are 177. We have crossed the halfway mark. So we are all good. Let us justify the presence of those who took the trouble to be on time and be with us already. Most welcome.
Okay. I think it is a topic of one full day discussion, actually. And very thankful to Dr. Srij sir for his kind words, and Ramadan sir and the entire Sitaram family. And why I selected the topic pitfall in spine-related orthopedics. Voice is clear, sir?
Absolutely. Perfect. Perfect for me.
Okay.
All of us, I suppose, yeah.
So the word pitfalls means it is actually not a tricky diagnosis. And as a scientific community, from the basic Ayurvedic doctor, I have seen so many cases from all over Kerala or all over India, referred from so many doctors for my opinion. And I have seen that some cases which are 100% surgical that are treated by various Ayurvedic doctors, institutions, and colleges. And the effect was 100% negative. And I have seen that so many cases were 100% failure. And one thing is important, that if it is surgical or if they have done the surgery, the patient was 100% okay. So our primary aim is the benefit of the patient, because most of the doctors are treating all the patients, and the ideal doctor, a best doctor, is getting best diagnosis and referring the patient if it is surgical or it is out of his hand. So that's why it is actually not a session, it is just a discussion regarding some cases that I have seen in my career and why I selected the topic. It is very important to avoid the complication because I have seen so many cases with that much life-threatening complication or lifelong complication like untreatable paraplegia or quadriplegia or some cases that can be treated with 100 or 200 rupees and it became a surgical with the treatment of Ayurvedic doctors. So to avoid complication, it is the most important role of a doctor because for example, we have sciatica for back pain and we have Giridesi. I think there are these two words. If any correction, you may correct. In our classic but considering the back pain or spine-related orthopedics, there are more than 100 or 200 diagnoses which are non-surgical because these are the cases we have seen in our OPD without we can treat these much cases without any complication, but there are few cases we should be refer the patient to a proper authority so that patient get maximum benefit. And the second one is to ensure the acceptance as a scientific fraternity because there are a lot of patients are coming to my OPD. Most of them are from reference from the Ayurvedic community and other modern community, especially orthopedicians and neurosurgeons, because they are all suggesting either conservative treatment or a surgical treatment, but and they are opting my OPD or me personally. Why? Because they have only one choice: either it is surgical, either it is conservative, and everyone should know whether it is surgical or conservative. And the best, you have to select the best part for the patient because you may miss the patient in your OPD, but lifelong they will remember you because I have so many. Because last Ramzan first day, I had a patient with severe back pain and he's having an numbness around the umbilicus and he is under treatment of an allopathic doctor last 3 years. And he's not taken MRI because of some financial issues. And I suggested treatment only after MRI report because I think it was something complicated and I suggested MRI and with a reasonable price, I recommended MRI. And it was a typical case of a tumor inside the spine. And now he underwent surgery and he is okay. Now he is doing his regular activity, daily routine. But at that time, Babinski sign was positive. And that umbilical around the that abdominal reflexes was exaggerated. So these are the some small points, even though he's under allopathic treatment for last 3 years. So it is not allopathic doctor, it is not a homeopathy or other system of doctors. They are not determining the diagnosis because I have seen so many doctors are following the allopathic not allopathic diagnosis from the orthopedicians. The orthopedicians or modern doctors are not a final word. The science or the modern science or an Ayurvedic science is a final word because they are human, they will be having some mistake in their treatment. Okay. So as a doctor, you have to get that acceptance from other scientific community, especially from modern, because I am still training under an orthopedic doctor. And we have almost 12 doctors, including 4 orthopedic surgeons. And still, I have a special role in that hospital because they know he's a Ayurvedic doctor with a post-graduation in Triviguna. But while I'm working in casualty, I will get my position. Even though there are so many MBBS doctors or DNB ortho trainees, I have my own place in that area. Why? Because I know the Ayurvedic part well and I know my limitation. Okay, so which area I have to send the patient for surgery and which area I can treat better than the modern orthopedics, because there are so many cases referred by the orthopedician from my clinic, my hospital for Ayurvedic treatment. So to get that acceptance from the scientific fraternity, you have to know the exact diagnosis, especially differential diagnosis, because a differential diagnosis is ideal than the diagnosis of the treatment. For example, if a patient is having severe back pain in the night, because actually it is a dangerous situation, it may be a malignancy, or it may be a tuberculosis, or it may be an avascular necrosis, or simply it may be inflammatory pain. So I'm telling, if it is a malignancy, you have to know why not it is an inflammatory pain, why not it is osteomyelitis or tuberculosis. So differential diagnosis, first find the differential diagnosis, rule out the differential diagnosis, and get a precise diagnosis. If it is treatable, just treat the patient, or if it is surgical, or if it is a part of a neurosurgery, you just refer the patient. Okay, it is ideal way of treatment to be a best doctor for diagnosing and for referring also. And the third one is your treatment should be less expensive, because I had a patient, I think 6 months back, patient with that genuvarum. I will show the slide. Genuvarum, typical case, and he is 8-year-old, and another case, it is a 2-week back with a typical 11-year-old boy with a varus deformity and limbing, and they suggested surgery, allopathy suggested surgery at the age of 2 years. It is very important, at the age of 2 years itself, allopathy doctor suggested surgery, but they done Ayurvedic treatment every year, and the patient is now 8 years. And again came to me for Ayurvedic treatment. First time I'm seeing the patient, and they're having the typical X-ray of the hip, and it was a congenital hip dislocation or a developmental dysplasia of it. It is 100% surgical, and with a cast, simple POP cast. Okay, so with a simple POP cast, you can treat the patient at the age of 2, and still the patient is 9 with a severe limbing, and he need an extensive surgery to correct the developmental dysplasia. But patient is having history of severe limbing, and with MR X-ray from the age of 2 years. And he is keeping the X-ray from the 2 up to 9, and he is visiting all the Ayurvedic doctors. Everyone are doing Piju, Dara, Vasti, everything, all the treatment, and still it is back, and doctors are suggesting every year Ayurvedic IP treatment. Okay, so actually it was a case of congenital dislocation, and another case was just a vitamin D3 deficiency, that it was rickets, and he underwent 56 years of extensive Ayurvedic treatment. Per day, 1,200 rupees, 56 days. Actually, it is a case of 200 rupees. So less expensive, and it should be more result oriented. So that you have to know the exact diagnosis, differential diagnosis, and treatment option. And why, when, where. It is very important why you have to treat back pain, when you have to treat, whether it is surgical or non-surgical, up to which area you have to treat, whether it is conservative, whether you have to do traction, or you have to give proper rest, or LS corset, or any other physiotherapy, any conservative treatment, when, where, and how. Because patients are asking questions. That last week I had a patient, that patient is having just a 2-month leave. He is abroad actually. It is a severe case of disc extrusion with caudal migration and having severe neurological deficit. Actually, it is not a Cauda Equina syndrome or a compressive myelopathy, but I suggested surgery because the patient is having only 2-month leave, and he's having heavy physical activity while joining his work. So for him, surgery is the ideal option. But if the patient is having 6-month leave or 1 month with a simple daily activity, means you can select conservative treatment. But I suggested surgery because he is having severe, he is just 34 year, young age, and is having heavy physical activity. So for his benefit, surgery is the ideal option. So why, where, when to select a conservative or a surgical option is very, very important. So that why I selected the topic pitfalls. It is actually a discussion, not a class. Okay, so everyone should be very important for history taking, because 70 to 75% of your diagnosing in all aspects are basically on history, and remaining 50%, 15% is that clinical examination, and just remaining 15 include that radiological and hematological investigation. So history is very, very important. So before starting a treatment of spine-related disorders, the age of the patient is very important. Because if the patient is having back pain or spine-related issues, neck pain, below the age of 18 or below the age of 20 or above the age of 55, it is very, very important that if a patient is below the age of 20, there are so many pathologies, especially tumor, that can be seen in children. It is very important. Osteomyelitis is the common one. Osteomyelitis, the tuberculosis is the common one, and the malignancy is common one. And in our normal practices, spondylolysis or pars defect or the so-called pars fracture is the common cause of back pain in children, especially below the age of 20. Okay, and if the patient is above the age of 20 or above the age of 55 or 60, a recent onset of back pain. If the patient is having already a chronic back pain and which is aggravating in the late age is not a factor actually. But if the patient is having a recent onset of back pain after the age of 55 to 60, definitely that means a recent onset of severe back pain or a neck pain or upper back pain, especially dorsolumbar pain, definitely you have to rule out the multiple myeloma. Because one patient from Calicut, and actually patient with a dorsolumbar pain recently developed, and he admitted in Ayurvedic hospital, and the doctor was one of my friend, and he called me that the patient is having severe back pain and she is under Ayurvedic treatment for 10 days already, under Dhara for 10 days, but according to the doctor, he is getting no relief. So he called me, so what we have to do in this case, any other treatment option? And up with the history, the patient is having no, actually he is an ex post department patient, and he is having no history of back pain and recently developed back pain. I think he's 72, and I suggested an X-ray of dorsolumbar spine and back pain. I have some doubt regarding the diagnosis, and again suggested surgery, MRI, and it was multiple myeloma. Okay, and he just referred the patient to a modern surgeon, and after referring the patient, 8 days after referring the patient, death of the patient. Okay, just 8 days from the reference. If the patient had a death from the Ayurvedic institution, what will be the result? Okay, there will be some legal issues for that doctor. So very important, recently developed back pain after the age of 55 to 60, you have to definitely treat the patient only after a proper X-ray if you are enough confident with the X-ray. Otherwise, just do an MRI whole spine, MRI lumbar spine or a dorsolumbar spine with whole spine screening, or MRI lumbar spine with whole spine, or if it is neck pain, MRI neck pain with whole spine screening. It is very, very important. A recently developed back pain after the age of 55 to 60, you just refer the patient for an MRI, and with the proper MRI report and assessment, you can start the treatment. So if any suspected lesion, or if the patient is not in a position to take an MRI, just send the patient for a blood investigation. And the basics of all the blood investigation in back pain is complete blood count, CBC, ESR, and CRP, and alkaline phosphatase. These are the 4 important investigation in spine or ortho-related issues, especially complete blood count, CRP, and ESR, and alkaline phosphatase. So these are the basic tests. Any abnormality in these tests, you can send to rule out that multiple myeloma. One is serum electrophoresis and urine Ben-Jones protein. Okay, so age is very, very important, and just to rule out age-related or these type of pathology before starting your treatment. And while taking the history, rest and the position of your sleeping is very, very important. It is very important not for the treatment, it is important not for your diagnosis. Because very simple example, patient getting better in prone position. Feeling better in prone position means typically it is a case of discogenic pain, or it is a case of mechanical back pain. That is very, very important. It is a case of mechanical back pain or a disc-related pain. So what is a mechanical back pain? That means patient get severe pain on physical activity or working and better with rest. That means if patient is in rest, is having no pain, when he started walking or working or any physical activity, the pain is getting aggravated. That means it is a clear case of mechanical back pain. So what is the treatment of mechanical back pain? I think it is very easy to treat a mechanical back pain, not with your medicine, because no medicine is working in mechanical back pain. Because patient is having weakness of the lower back muscles, weakness of the abdomen. It may be due to central obesity, or it may be due to postnatal. So in mechanical back pain, that means patient with severe back pain on physical activity and no pain with rest. That means it is typically a case of mechanical back pain. Just start spine extension exercise for minimum 3 to 6 months. Along with that, you can add Thyla or any external application or a small medicine. It should be cost effective, because with a cost effective treatment, you can treat that mechanical back pain. So in such cases, patient get better relief with rest. Okay, and in prone position, another one is a discogenic pain. So for diagnosing a case, patient is telling that I have severe back pain in the morning or while doing sitting or driving or my daily activities, and you can ask the question, what is your condition on waking up from the bed? So if patient is telling that I am better, I have no pain in the morning, means either it is a mechanical back pain or either it is a disc related or discogenic pain. So in some cases, you can treat. Then if it is a discogenic pain, means you can send the patient for an X-ray, an abnormality in the X-ray, and after your clinical evaluation, you may send the patient for further investigation. And another one is in supine position. And so many patients are complaining that I have severe pain in the back and I can't even change my position in the morning or during the sleep. It is very, very important. Severe pain in the back, especially in the morning. And I can't change my position during the sleep, or I can't change my position even on sitting. And it is a typical case of inflammatory pain. Very, very important. Typical case of inflammatory pain. Patient is having severe pain on changing the position during the sleeping, and severe pain on waking up from that sleeping position. Waking up from sitting position is typical case of discogenic pain, and it will relieve in the morning. That means maximum relief during the rest. Typical case of discogenic pain. And severe pain on waking up from the sleeping position, it is an inflammatory pain, because it is very important for your treatment. Because never spoil any medicine, because our medicines are so expensive. So there are some cases, I have seen some case of typical case of disc bulge or disc prolapse or protrusion or extrusion with a severe radiating pain. Actually, these are all discogenic pain. Bulge, prolapse, protrusion, extrusion, we will discuss in detail. These are all typical case of discogenic pain. But usually in discogenic pain, pain will be less or no pain in the sleep or in the morning. But there are some cases, it may be bulge, prolapse or protrusion or extrusion or severe radiculopathy. Patient is having severe pain in the morning. That means it is a typical case of discogenic pain, but patient is having some inflammation in the back. So your treatment of option is subside the inflammation first and treat the discogenic pain next. Otherwise, if you are selecting discogenic disc-related treatment, it will be a good, it is a utter waste. Or you can start in case of inflammatory pain, Lebana with Churna is the ideal option. That I have seen so many patients, they are having severe radiating pain, but there will be severe pain in the morning or changing the position in the bed. That means it is a case of discogenic pain with the inflammatory process in the back. So you have to subside the inflammation in the back. You can use that RASAAYANAM kashaya. It is the ideal option for inflammatory pain in the morning. RASAAYANAM kashaya. Along with that, you can use Nagara Jadamyadi or Gradumadi Lebana. With Lebana and kashaya itself, you can reduce the morning stiffness. after subsiding the morning stiffness or pain in the morning, you can't start your discogenic treatment. And if you are opting any other treatment like traction or any manipulation in the inflammatory pain, it will be a failure because pain will be severe if you are adopting this much treatment in the inflammatory area. So even though it is discogenic, if there is inflammation, you just treat the inflammation first, and you can decide whether it is inflammatory or discogenic with the position of the patient. Okay. And sitting, that means it is typical case of discogenic pain. Patient is having severe pain in the sitting or pain after waking up from the sitting position. That means it is a typical case of discogenic pain. And in case of discogenic pain, spine extension exercises are advisable. Never advise any flexion exercise. Okay, in case of discogenic pain or mechanical back pain or any normal back pain, spine-related extension exercises are advisable. But in case of inflammatory pain, which is better in supine position, flexion type exercises are advisable only after subsiding the pain. Okay, and standing and walking is very important. There are so many cases patients are telling that I feel better on sitting, because usually in discogenic pain or in back pain, the most culprit is sitting for a long time, that I have pain in back while sitting for a long time. But patient is telling that I have severe pain on prolonged standing or prolonged walking because I can't stand for a long time or I can't walk for a long time, but I can sit. So this is a typical case of spinal canal stenosis, or it is otherwise called neurogenic claudication. That means there are stenosis or reduction in the spinal canal or in the neural foramina. It may be due to disc bulge or any other anatomical changes. So patient is telling better with sitting, but on prolonged standing or starting walking, I feel severe pain and crampy pain in the calf, and I have to stop and sit. Not stopping, I have to sit to reduce the pain. If I'm standing for a long time, I will have severe pain in my calf and back. And if I'm just sitting, the pain is reduced. So standing for a long time, walking for a long time is severe pain, and I'm just sitting after standing or walking means the pain will be reduced by itself within a second. So it is a typical case of spinal canal stenosis. If it is due to discogenic pain, it is due to severe posterior or posterocentral disc bulge, we will discuss. If it is due to severe disc bulge, the option is Mahamajistadi Kashayam and Asanirandadi. If it is due to that ligamental phloem hypertrophy or arthropathy of the facet joint, Mahamajistadi with Varanadi, and that Aranda Thaila, Aranda Snehapana is the ideal option. So it depends of the condition of the patient and it is due to the pathology. Dindana Parivarjanam is the treatment actually. If we are assessing the exact pathology, it is very easy to treat. So standing and walking aggravate the pain, and with sitting, the pain is subsiding spontaneously, means it is a typical case of spinal canal stenosis. Then next one, what is the time of onset of the pain? In the morning pain that I already explained, it is a typical case of inflammatory pain. Morning pain with stiffness, that means it is a inflammatory arthritic pain. In case of discogenic pain, there will not be any stiffness, there will be severe pain. If it is pain with stiffness, usually it will be an arthritic pain, inflammatory arthritis. And there are night pain and late night pain. And case of night pain, this is the most dangerous situation. Patient is having back pain in the morning or in the daytime, and it will be severe pain in the night. I have seen one patient referred from Wayanad district, one of my friend doctor, and the patient is just 32 years. She is an allopathy nurse having severe pain and admitted in Ayurvedic hospital, having normal pain in the daytime and severe pain in the night. And we had a discussion with the doctor, and I suggested MRI. And the history was patient is doing Daira, etc. Having severe pain in the night, but she'll be having normal pain in the daytime. And they suggested allopathy, and they take just X-ray, and they are telling this just that inflammatory pain, just suggested some analgesic and steroid. And again, they're back to Ayurvedic treatment. And the daytime it is okay, and again in the night it will having severe pain. So it is 2 or 3 episodes of the Ayurvedic and allopathy, and he discussed with me. I suggested an emergency surgery, emergency MRI, because night pain, normal daytime pain with a night pain, is a typical presentation of either a malignancy or a tumor or any other inflammatory like osteomyelitis or tuberculosis. Actually, it was a typical case of malignancy, and it is actually metastasis into its pelvis. Just a 32-year lady with a severe presence, and another case of a patient already undergoing treatment, and after the treatment of 21 days, not getting any result, and doctor discussed. I suggested an MRI, emergency MRI, and it was a metastasis. And one case of mastectomy, means the previous case of CA with a severe back pain. So it is very important that night pain is very important, that it may be a malignancy or it may be an infection. It may be osteomyelitis, that is that inflammatory, and it may be a tuberculosis like Alta abscess, or it may be an avascular necrosis. It may be a malignancy, or it may be an infection, or it may be an avascular necrosis. If the patient is having more pain in the night, it is very, very important. Okay. And in case of malignancy, it is very important a previous history of malignancy presented with back pain. Definitely treat the patient only after taking an MRI whole spine. It is enough. Okay. And in late night, because I have seen so many patients with late night pain, maybe after one episode of sleep, patient gets severe pain in the back, especially in the upper back. You have to send the patient for blood investigation alone. It may be either hyperuricemia, or it may be due to vitamin D3 deficiency. The patient having late night and morning pain, it is very important. Late night and morning pain, it is having vitamin D3 and deficiency or hyperuricemia. Because I have seen so many patients underwent Ayurvedic treatment, especially that 21 to 30 days of Ayurvedic treatment, IP treatment for this. And it was actually a case of 100 or 200 rupees of treatment. So before starting your treatment, just go through the investigation and get a proper diagnosis. And the location of the pain, it is very important that the fracture of the spine is more common in the dorsolateral area. That why? Because there is a flexible cervical spine and a flexible lumbar spine, almost rigid dorsal area. So the most important area of fracture is dorsolateral area. And it very, very important is you know that the spinal cord end at the level of lower end of L1, and there are plexus, that is sacral plexus and lumbar plexus. And usually the sacral plexus is at the level of T9 to T11. And the sacral plexus is, lumbar plexus is T9 to T11, and that sacral plexus is T11 to L1. And these areas having all the nerve root from L1 to S5. So any injury to this T9 to L1, that is the thoracolumbar area, is that much crucial to the patient. So any injury, you should be conscious. That's why I'm telling that any injury to spine, you have to examine the patient thoroughly. We will discuss it later. Okay. So another one is renal angle. Renal angle, it is very clear that you have that erector spinae muscle, lateral to erector spinal muscle, and lower to the 12th rib. It is the area of renal angle. I have seen the patient, there's the same that having Ayurvedic treatment and Ayurvedic OP level treatment for 6 months. Actually, it was a case of calculate. So it is very easy. So clinical examination of the patient is very important before starting your treatment. And the sacroiliac SI joint, we can test the patient with Faber test, and it's a chronic case of sacroiliitis with a normal blood picture. Definitely ankylosing spondylitis you have to rule out. And limbing in adult and children is another important topic. So you can see an X-ray with a 20-year-old football player without a specific history of trauma. You can see without a specific history of fall or trauma, and it is a case of low back pain. 3 months back without a radiating pain. It is very important. He's having low back pain, no history of trauma. He's a football player without radiating pain, having severe low back pain. And you can see this is the case 3 days back, just added in the slide. 3 days back, he's just 20. And can you see the patient with L1, 1, 2, 3, 4, 5. And this is the 6th one. It is actually a patient with a lumbarization. And the most important diagnosis is a patient is having a spondylolysis or pars defect or pars fracture in the L5 vertebrae. So pars defect in the L5 vertebrae. So it is the commonest causes of back pain below the age of 20. And it is very important in this case, then it is very important that patient have to use lumbar corset for daily activities. and you have to start the treatment with Googly Tiktak. It is the ideal option for spondylolysis and listhesis. It's my opinion. Googly Tiktak Rhythm or Googly Kashayam. Along with that, lumbar corset, and when the pain subsides, you can start flexion type of or flexion bias exercise for a complete relief. Actually, usually our doctors are asking the patient whether you have any injury or fall, and they are explaining to the patient that this fracture or this so-called a new term that pulse fracture, it is actually not a fracture, it is a defect actually. It is a defect during the development of the neural area. So it is not a fracture and it is not due to any fall or injury. It is very important. It is not due to any fall or injury, because any injury to spine, there is an area like vertebral body or transverse process or spinous process or facet that the commonest area of fracture. And this is area that pars intraarticularis. It is never break during normal fall. So never tell any patient that this pars defect or pars fracture is due to your fall. It is developmental actually. It is very, very rare that there is a fracture due to any injury. So never discuss regarding the fracture and the origin is due to that any injury. Actually, it is a developmental. So it is a case of 20 years. So just start Googly Tiktakam like treatment, especially Gritapanam and lumbar corset, and start a flexion type of exercise and ask the patient to rest in supine position. It is very important. Ask the patient to take rest in supine position. And it is very important that in case of spondylolysis and listhesis, just 3 or 5 day rest is enough. Never ask the patient to rest for 1 month. It is unscientific. Just give a minimum 3 to 5 rest if the patient is having severe pain. Otherwise, rest is not advised in spondylolysis or spondylolisthesis, and you can use lumbar corset. It is mandatory in spondylolysis and spondylolisthesis. With Googly Tiktaka Gritapanam or Googly Kashayam found to be the ideal option in spondylolisthesis or spondylolysis. And another one, a 13-year-old girl with genuvarum, bilaterally without any specific history of trauma, approach for Ayurvedic treatment. And it is very pathetic that doing Ayurvedic IP treatment in every year from 2 year till date. Doing IP treatment in every year from 2 year onwards. So what is the condition? Can you see the patient? She visited, I think, last 2 months back, I think. You can see this is a typical case of untreated rickets. Just an untreated rickets. Patient is having a severe genuvarum. Varum is developed and she is now 13. So very important that if clinically, if you are treating very varus or valgus deformity, if allopathy is suggesting surgery, and it is ideal to rule out what is the exact pathology behind this case of rickets. It is very important that if a patient with a normal birth history, full-time normal delivery or a LC, that lower segment cesarean session, if the patient is neurologically normal during the birth or any normal birth without any specific trauma or any underlying pathology, if patient is having a normal birth, if patient is not walking or not doing regular that milestones, especially walking after the age of 1, it is very important in our Ayurveda, that is the term Phaka is used for diagnosing the condition. That patient is not walking after the age of 1, definitely you send the patient for that CBC, vitamin D3, calcium and alkaline phosphatase. It is very, very important, because from the first year and some patients are normally walking at the age of 1 where they are developing mild varus deformity. You can see the picture with mild varus deformity or varus of the lower limb or varus just above the ankle. So either the presentation may be patient is not walking even after 1 year, or it may be there may be some limbing, or there may be some varus deformity. So these are the 3 clinical presentations. Either patient is not walking even after 1 year, or the patient is having some varus deformity in the knee, or the patient is having some limbing. These, if the patient with 1 year patient with this presentation, definitely you send the patient for blood investigation, CBC and vitamin D3, calcium and alkaline phosphatase. If you are if these parameters are normal, that means it is a physiological condition, or it is a normal physiological bowing. It is not a rickets. Okay, and it is ideal to take an X-ray of both the wrist AP to rule out that epiphyseal growth. Okay, and along with that, you can have that femur with knee or knee with leg for assessing the epiphysis. So blood investigation at this picture, if it is normal, just leave the patient, because up to 3.5 year rickets is physiological, or this bowing or limbing is normal and it is physiological. And even after 3.5 year, if there is any abnormality or any limbing, so any bowing of the lower limb, you have to use that night splint. It is very important. You have to treat the patient with your IP along with night splint. And if the patient is 8 to 10 year, even after 8 year, definitely you have to send the patient for surgery. So after 10 year, so I have seen in my house residency day, I have seen some patient, they are treating genu varum with Ayurvedic treatment. Okay, because children with genu varum, it is not a post osteoarthritic genu varum. You can treat genu varum. Actually, it is not treatable, but to relieve the pain, you can treat osteoarthritic genu varum. But it is not an osteoarthritic genu varum. Children with genu varum, you can treat up to 8-year-old, because after 10-year-old up to 13, these epiphyses are fusing. So below 15, the surgical option is just adding a clip. And if the patient is above 15, it is very clear that the surgery is much complicated, because the high tibial osteotomy is the surgical option after the age of 15. After the age of 10, just adding a clip to the epiphyse, it is a minor surgery. So it is our area is that after 10 years, never treat any patient with this type of genu varum, which are actually treatable below the age of 8. It is very, very important. You should be scientific, just the sending patient for this type of investigation if the patient is below the age of 8, because never spoil our name. It is very, very important. And a back pain patient, another one with left radiating pain and limbing, and it is treated by a medical officer, and patient is diagnosed as osteoarthritis. It is diagnosed as osteoarthritis. Actually, the patient is having severe knee pain and some back pain, which may be radiating up to knee. So it is very important that any patient, any back pain which is radiating up to knee, you have to rule out hip pathology, because in sciatica, the presentation usually radiate below the knee. In case of lumbar pathology, the pain usually radiate below the knee. In case of hip pathology and femur-related pathology, the pain in case of hip-related pathology, the pain never radiate below knee joint. So you can see this patient, it is actually a case of carcinoma. Okay, it is not a case of, and it is very, very pathetic that we are treating carcinoma as osteoarthritis. So you can see this patient, can see it is a carcinoma actually, and you can note the age of the patient. She is just 19. So any patient below the age of 20 presented with spine disorders, knee pain or back pain or leg pain, definitely send the patient for investigation and start treatment only after getting a precise diagnosis. Actually, the patient is advised to do chemotherapy, and I refer the patient to the MVR Cancer Center. And this is actually a pathetic condition that we treated it in Ayurveda as Sandigadavada. Okay, so just take an MRI, just take an X-ray, just 200 rupees for an X-ray. Just takes an X-ray before starting every treatment, and you can see these much changes. You can see that outer cortex in your medullary cavity. Okay, so actually in early stage you can treat very easily. If it is late, means it is much complicated. So you start any orthopedic treatment simply with an X-ray, because X-ray is the golden standard for diagnosing a tumor. Any abnormal growth you can diagnose simply with an X-ray. So X-ray is cheap and best for diagnosing any tumor or any abnormal growth. for diagnosing a disc-related issues or any spondylolysis or elisthesis, or any tumor, any abnormal growth, anything you can diagnose with a simple X-ray. So just send the patient for an X-ray before starting your every treatment. Okay, and you can see a patient with the night pain, and you can that it is a very typical case of, you can see in X-ray there are iliopsoas muscle shadow on either side of them. And you can see there is abnormal. The patient is having severe back pain, and he is not taken even X-ray last 6 months. You can see the changes in this X-ray. Can see the changes in the vertebral body. So it is, I'm actually, time is limited. Otherwise, there is even the shape of the vertebrae is very important. If there is a biconcave deformity, it is a typical case of osteoporosis. If there is a wedging, it is a fracture. If this is a posterior concavity, that means there is a intraspinal tumor. If it is squaring of the vertebrae, it is an angulation spondylitis. So with the shape of the vertebrae, you can see the shape of the vertebrae here. Shape of the vertebrae, there is an that non-sclerosis type of lesion. You can see an abnormal growth in the paraspinal muscle. So the result was actually there is a possibility of expansive lesion of the L1, maybe a metastasis or plasmacytoma or giant cell tumor. So it is very simple that patient is having just back pain, just upper back pain which aggravate in the night, and the diagnosis was a possible metastasis. Okay, then so how you can differentiate back pain and hip pain? It is very important that I had seen so many patients from our community that are treated hip-related pathology as back pain. So I'm repeating, back pain always radiate, especially sciatica, always radiate below the knee, because the sciatic nerve is composed of L4, L5, S1, S2, and S3. All the dermatomes are almost dermatomes, especially it is below the knee. So usually the pain in the calf muscle and in the foot, and the presentation will be mostly below the knee. But hip-related pathology, it will never radiate below the knee, and it will be always confined to back and up to knee. So clinical history is very important. And you can see in case of hip-related pathology, test with the Faber. Faber means it is otherwise called figure 4 test. It is very simple to differentiate hip-related pathology from back pain. Ask the patient to do a Faber test. You just know the term Faber test. Flexion, abduction, and external rotation. That is Faber test or figure 4 test. If you are unable to do the figure 4 test, means there is some pathology in the hip. So it is ideal to write the prescription that usually LS spine, lumbosacral spine, epilateral is the ideal option for back pain or sciatica. So it is simple to change a modification in the X-ray that lumbar spine, LS spine, epilateral. Normally, LS spine with both hip AP and LS spine lateral in case of a suspected hip pathology if a patient is having back pain. So with the same X-ray, with the same expense, you can rule out hip-related pathology. So if the Faber test is positive, it may be either a hip-related pathology or it may be a sacroiliitis. Okay, it is very important. It is either a hip-related pathology or a sacroiliitis, and then it is better to ask the patient to lay down and flex the hip and knee in 90 degree and try internal and external rotation. It is very important, and limited internal rotation of the hip. It is very important, limited internal rotation of the hip. That means the leg is moving outward. In case of hip, internal rotation means the leg is moving outward. It indicates a clear case of hip pathology. It is very simple to rule out hip-related pathology. So it may be a progressive osteoarthritis or it may be a vascular necrosis. And in children, it may be a Perthes disease. It is very important how to differentiate these type of cases. So do a Faber test and internal rotation in a flexed hip. And in case of children, hip abduction, it is very important. So any limited abduction in children, ask the patient to lay down, and a limited abduction of the hip in children, definitely there may be a pathology related to hip. You can see a simple test of ELISA. I have seen so many patients, they are telling that those Vaidya told me that my limb is having length difference, my children having length difference in lower area. So this is the opinion from Vaidya. Usually, common peoples are more believe in Vaidya than Ayurvedic doctor because we are doing this much in our OPD. So to rule out how to differentiate the limb length discrepancy, which may presented as a back pain, I will show one X-ray because this is already treated as sciatica because actually it was a case of untreated hip dislocation. So it is very important how to differentiate, how to correct, how to measure whether it is limb length discrepancy or difference in the patient. You can see Alice sign, and it is very important that both toes are in same level and patient should be at the center. And usually if the patient is having a normal bilateral limb length, the height of the knee should be equal. It is very, very important. It is simply called the Galeazzi test to rule out limb length discrepancy even in adult or even in children. Okay, so in the Galeazzi test, if the that height of the knees are equal, that means the patient is having no limb length discrepancy, even though it is said by a Vaidya or orthopedician or anyone. Orthopedicians are not an ultimate word. Science is the ultimate word. We have seen that the orthopedician said that it is having this much. It is not science because in Galeazzi test, if the fingers are in the same level and if the length or the height of the knee is in same level, that means the patient is having no limb length discrepancy. And in children, it is very important that limited abduction, because I have seen if you are trying to do the Galeazzi test, you can see the hip of the children are so flexible that you can move any area. But if there is a limited abduction in the hip, that means there may be some pathology in hip-related pathology. So it is very important what are the conditions which may cause that limbing in children or limbing in adult. It is very important. So up the age of 3, so up to the age of 1 to 3, what are the conditions which are possible in children? Because these are very crucial, because your opinion as a doctor, your opinion is very important for the patient, whether it is surgical, whether it is treatable, whether it is referred. Okay, so which are the conditions we can see in this area, especially people or the children with limbing? It is very important. So up to the age of 3, there are so many conditions. The most important one is neuromuscular issues. It is very, very important. Neuromuscular issues. So if a patient is having any birth injury, so neuromuscular injuries are very, very important. And juvenile idiopathic arthritis, and congenital hip dislocation. Okay, and limb length discrepancy. It is very, very important. And another one is septic arthritis. So below the age of 4, so the age itself is important. Already told it is below 15 and below 20 and above 45. So in case of children with limbing, up to the age of 3 or 4, it may be a septic arthritis. It may be a congenital hip dislocation. It may be a juvenile idiopathic arthritis, or it may be a limb length discrepancy, or it may be a neuromuscular disorder. So it is very easy to go for an X-ray pelvis with both hip AP and frog leg view. You can rule out any type of that, except that septic arthritis. You can see the neck difference, and you can see the congenital hip dislocation, and you can see the along with blood investigation, you can see the arthritis. So these are the pathologies you can see up to the age of 4. And if a patient above the age of 4 up to 10, the most important presentation will be that Perthes disease. Usually Perthes disease never presented below the age of 4. Perthes disease duration is usually between 4 to 8. So the age is very important. So the one of the presentation after the age of 4 up to 10, it is most important is Perthes disease. That is Lekave Perthes disease, the most common cause of limbing in children. Okay, and another one is septic arthritis, limb length discrepancy, and juvenile idiopathic arthritis. So these are the 4 important diagnoses if the patient is from 4 to 10. And usually I have seen some patient with Perthes disease after the age of 10. Actually, it is a case of untreated Perthes disease, because the presentation of Perthes is usually between 4 to 8. So I have seen a patient, she's actually 13 with an untreated Perthes disease. Okay, untreated perthes you can see after the age of 10. Usually it develops between the age of 4 to 8, and usually during the period it will be diagnosed by the parents or the orthopedicians. Okay, and after the age of 10, it is very important. After the age of 10, you can see that SCFE, slipped capital femoral epiphysis. It is very easy to diagnose. Patient with obesity, especially male patient with obesity, between the age of 10 to 17, developed with limbing. Mostly it will be typical case of slipped capital femoral epiphysis. And you can see Perthes disease if it is untreated. Okay, and there are so many conditions, and it is very clear that you will diagnose all the pathologies I already explained in the respective duration. So after the age of 10, it may be usually that slipped capital femoral epiphysis, or there may be untreated Perthes disease or untreated congenital hip dislocation. So these all the pathologies you can diagnose with a simple X-ray. And after that, there may be limbing due to some foot issues like tarsal coalition or vertical talus. And you can see some kyphosis if the patient is having a flat foot. So it is very important. And in our OPD, you can see plantar fasciitis. The common area of foot pain is plantar fasciitis. If a patient is having severe plantar fasciitis, even after treatment, it may be related to a cord pathology. It is called a tethered cord syndrome. Tethered cord syndrome means usually the spinal cord end at the level of L2. And in some cases, the spinal cord end below the level of L2. It is called tethered cord syndrome. In such cases, the most important presentation not will be a back pain, actually, it will be a plantar pain or a foot pain. So if untreated means you have to know that there are some underlying other pathologies which may predispose as back pain or limbing or foot pain or knee pain. Okay, then another area, it is very important area, which is disc related terminologies in our OPD treatment. You can see this video, just go through the video. What is the pathology actually? So this is a case of how disc bulge is happening. You can see this is a posterolateral disc bulge, ventral and thick. So this is just a video. What is the relevance in our clinical practice? It is very important. What is the relevance of these terminologies in our practice? So you can see there are so many terminologies in disc bulge, whether it is treatable, because I have so many calls from so many doctors that whether it is treatable. Usually most of the cases, 99% of the cases are treatable by successfully treatable than modern orthopedics with our treatment. But it should be more scientific approach to this whole area. You can see one slide with one picture with a normal disc, and you can, and the picture and the presentation differ from each radiologist because the terminologies are entirely different from one radiologist to other. Because so you just go through the history, then clinical presentation, then X-ray, then MRI film, and finally the opinion from the radiologist, that is the MRI report. Never go to the MRI report initially, just go through the investigations and interrogation and history, and finally the MRI report. So you can see the diffuse disc bulge. You can see the diffuse disc bulge. The term diffuse means the pressure from the nucleus is spreading all over the area uniformly, so that there will be uniform bulge towards the area. So the presentation depends on the exact area where actually the bulge is more. So in case of diffuse disc bulge, there may be pain mostly in the back, and the radiating pain will be less. If so, there will be less radiating pain. And you can see the third one is the asymmetrical back bulging. So what is the difference between diffuse bulging and asymmetrical? In case of a diffuse disc bulge, the pressure will be more related to the back structures. So there may be a pressure effect, there may be an inflammatory effect, there may be a discogenic effect. And in case of asymmetric disc bulge, the pressure effect will be more towards the specific area. It may be a spinal cord or it may be a nerve root, so that the back pain will be less, and there may be severe pain if it is directed towards the spinal cord. Sorry, directed towards the nerve root. And in such cases, the back pain will be somewhat less compared to that specific radiating pain. Okay, and another terminology, that circumferential disc bulge. This is same terminology. It is usually, this is terminology from the radiologists that are graduated from abroad. They are using the term circumferential disc bulge. Okay, so diffuse disc bulge and circumferential disc bulge are both are same. Okay, then you can see the MRI picture, transverse section of an MRI picture. So it is the nucleus actually, and there is an annulus. So you can see this is the just behind it is the spinal canal. This is the ligament flavum on either side. So this is the facet joint, and there is, so this is the area. This is the white area. It is called patient's right neural foramina, and it is a left neural foramina. You can see the left neural foramina, which is occluded by a disc bulge. And you can see it is called the focal disc bulge. So what is diffuse disc bulge means? It is bulge all the boundary of your disc is diffuse disc bulge. One focal means it is pointed. That means there is a maximum pressure over the specific area. So in this pathology, you can see this is a case of patient with left neural foramina. My cursor, you note the cursor, this is the area with the left neural foramina stenosis, and the patient will have severe case of left sciatica. It is very important that, and with the picture, you can imagine that if the patient is so young and the patient is, you can see a white nucleus and black annulus. That means there is no disc desiccation. That means the patient is usually age below the 30 or 40, and the patient is, the presentation will be usually an acute onset of pain, usually after an RTA or a fall or injury. So with the investigation, with the film itself, you can diagnose whether it is age related, because you can see a white colored nucleus and outer black colored annulus. White colored nucleus and annulus is the normal presentation in MRI. If it is completely black, annulus and nucleus is black, means it is disc desiccation or disc dehydration. So it is usually age related. Okay, so this MRI actually, a patient which is normal muscle or normal spine anatomy or spine structure, spine strength, with a possible history of fall or injury. And you can see left neural foramina stenosis, and it is a focal disc bulge. Focal means area, a pointed disc bulge. And the similar case, you can see it is a normal disc carrying white nucleus and outer annulus. And this red color is the spinal canal. This is a neural foramina. Okay. Similarly, the second one, it is a diffuse disc bulge. And you can't see any white color in the MRI. That means it is a disc with this having disc dehydration or disc desiccation. And you can see this is a normal boundary of your disc, and you can see there is a disc. This is a left neural foramina. It is occluded. The right neural foramina, it is also occluded, and you can see the spinal canal is reduced. So it is a case of, you can see the cursor, it is a case of typical diffuse disc bulge. A disc bulge which is diffuse, so it occlude the neural foramina, it occlude the spinal canal partially, it occlude the right neural foramina. So in such cases, the pressure will be less in each and every area. In case of focal disc bulge, the pressure is focused to a specific area. So in such cases, there will be severe pain. If it's a focus towards a nerve root, there will be severe case of radiculopathy rather than a normal back pain. The patient will be having no back pain with the severe radiating pain in case of focal disc bulge. It depends on the area where the disc bulge is located. And in case of diffuse disc bulge, there will be uniform distribution of the pressure over both nerve root and spinal cord. So in these two conditions, rest is the ideal option. With the rest, you can reduce the pain, especially in case of diffuse disc bulge. There will be maximum benefit if a patient is having rest in diffuse disc bulge than focal disc bulge. So it is very difficult to treat a focal disc bulge, and it is very easy to treat a diffuse disc bulge. Okay, and disc-related terminology. There are 4 terminologies. One is disc herniation. Actually, the term disc herniation is The term disc herniation is actually a common terminology, and it includes disc bulge or otherwise called disc prolapse, and disc protrusion and disc extrusion, disc sequestration. These are the four terminologies we are usually using, and the term disc bulge is usually normal one. So everyone after the age of 20 presented with disc bulge, may be having disc bulge. So the term disc bulge or prolapse, it is a diffuse symmetrical outpouching beyond a normal disc level. Actually, it is normal. It is age related. It depends on the strength of the back muscle. It depends on the strength of the abdomen, and it depends on the central obesity and physical activity. So diffuse disc bulge or prolapse, it is a normal one. Actually, clinically, it is a normal. And disc protrusion means it is a focal asymmetrical expansion. So symmetrical bulge is disc prolapse. So it is very easy to treat with a rest. 5 days complete rest in prone position is the ideal option for disc bulge. And disc protrusion means it's a focal asymmetrical disc material, disc bulge. So there will be severe pain, and if it is related to any nerve root, there will be severe radiating pain. And both the conditions are reversible with rest. It is very, very important. Disc protrusion means there will be a focal disc bulge, a focal asymmetrical expansion, and it is not beyond a normal level, and the nucleus will be inside, and there will not be any break in the outer annulus. It is very important, and both these conditions are reversible. And the last one is extrusion and sequestration. So in modern orthopedics, extrusion and sequestrations are surgical. Extrusion and sequestration are surgical, but in our concept, even though all the parameters, all disc bulge, prolapse, protrusion, and extrusion, you can treat every patient if the patient is having normal clinical presentation. That means even though sequestration and extrusions are surgical, you examine the patient clinically and neurologically. If the patient is stable, you can treat extrusion and sequestration, even though modern orthopedics, they are suggesting surgery in case of extrusion and sequestration. Okay, so this, you can see a simple explanation of these all the characters. So this is a case of a normal disc. You can see this is case of a diffuse disc bulge. You can see this is a case of focal disc bulge to a specific nerve root. And in case of disc extrusion and sequestration, you can see the disc material come out by breaking the annulus. So up to that area, there will be maximum pressure inside the disc. This is very important. In case of disc bulge, this is a diffuse disc bulge, pressure will be uniform. In case of disc protrusion, it will be focal. So there will be maximum pressure. So patient is having severe back pain. And if it is related to any nerve root, there will be radiating pain. Okay, so in these cases, pain will be more in the back, and there will be no pain in the rest until it is related to any nerve root. So it is very easy. If the patient is having only a back pain, that means it may be a bulge or disc prolapse. There may be some frequent sciatica. It depends on the position of the disc bulge. And if in case of disc extrusion and sequestration, the disc material come out by breaking the outer annulus, that means the pressure inside the disc is reduced, and the material come out of the annulus or a disc, and it may lodge into the spinal canal, or it may lodge into the neural foramina. And the back pain will be completely relieved, or will be a slight back pain, and there will be severe radiating pain or lower limb symptoms. So if some cases, I have seen some patient, they are reporting that after Ayurvedic treatment from an institution, I have back pain during the treatment, and the back pain and without any radiating pain. The patient is having back pain during the treatment without any radiating pain, and the patient is telling that I have severe lower limb pain, and my back pain is completely relieved after the Ayurvedic treatment. Is the treatment is successful or not? That means the patient is having severe pain during the treatment, and after the treatment, the complete back pain is relieved, but the patient is having now radiating pain. That means it is a bad prognosis. So in bulge or prolapse, there will be severe pain in the back due to the pressure effect, due to inflammatory effect. Okay, and the nociceptive receptors of the outer annular margin. So pressure effect is there, inflammatory effect is there, nociceptive effect is there. But once in extrusion and sequestration, once the annulus is broken and the materials come out, and it presentation depends on the where the disc material is lodging. It may be narrow root, it may be lateral recess, it may be a spinal canal. So in such cases, back pain is almost relieved, and the severe pain or severe presentation will be in the lower area. So some patient may present with a severe calf pain without any pain in your OPD. You have to rule out the extrusion and sequestration. It is very, very important. You can see the protrusion with the maximum pressure effect, and extrusion means pressure effect is reduced and the material is maximum outside. And you can see some terminologies in MRI like superior migration, extrusion with the superior migration. It is otherwise called cranial migration. If it is migrating toward the lower side, it is called a caudal migration. And in case of disc sequestration, sequestration means the extruded material becomes separated and it lodged into a specific area. It becomes separated. In case of extrusion, there will be contact with the mother area of the disc. So it is the case of disc extrusion with the caudal migration. There will be contact with the mother area. And in case of sequestration, the material is separated and is lodged. And it is very important that in some cases, there will be absorption of the body. This part is this extruded, this sequestrated material is called sequestrum. It is sequestrated material may be absorbed by the body and it will be completely. So in both sequestration and extrusion, the bed rest advised is 1 month complete bed rest. It is very, very important. Complete bed rest means even the daily activities, urination, even defecation, it is ideal to do on the bed. So this much 100% bed rest will relieve extrusion and sequestration in 80%. So after that, you can start your treatment. If it is a bulge or prolapse in the initial stage, 5 days of ideal bed rest is mandatory. In case of extrusion and sequestration, 1 month complete rest, there will be 80% reduction of the pain. Even after 6 months of successful treatment, if the pain or conditions are worsening, you can send the patient for surgery in case of extrusion and sequestration. So there are some terminologies. Again, this video. Okay, so there are some terminologies. You can see, you can assume a clock. It is very important because without assuming the terminologies in MRI, it is very difficult to assess the MRI clinically. So you can see this is the nucleus. You can see this is the outer annulus, and just behind you can see this is the spinal cord. Okay, and you can see it is the facet joint, upper facet. You can see it is a nerve root. Okay, on either side. So it is a ventral root for that motor, and this is a sensory. So this is a nerve root, and this area it is called neural foramen. This is the neural foramen. The area between neural foramen and spinal cord, this is called the lateral recess, and just behind the that disc, it is called the spinal cord. So it is very important that you assume one clock, and you can see this is a 12 o'clock. You can see this the disc is you watch my cursor. It is a 12 o'clock, and this spinal cord is 6 o'clock. So it is 12 o'clock. It is 6 o'clock, and you can see it is 9 o'clock and it is 3 o'clock. So just assume a clock that disc is 12 o'clock. So in case of MRI, you can see so many terminologies like central disc bulge, posterior disc bulge, or posterocentral disc bulge. It is very, very important. That means the disc is protruding or disc is bulging directly towards the spinal cord. It is very important. Posterior disc bulge, central disc bulge, or posterocentral disc bulge means it is directly towards the spinal cord. That means you should be conscious while treating posterior, central, or posterocentral disc bulge, because the disc is bulging or protruding or prolapsing directly towards the spinal cord. That means towards the 6 o'clock position. It is very important. So to 6 o'clock position, it is posterior, central, or posterocentral. These are the terminologies in MRI. And another terminology, That is median or paramedian disc bulge. It is very important. Median or paramedian means you assume a clock, it is 6 o'clock, it is towards 7 o'clock, or it is towards the 5 o'clock. It is towards the spinal cord, but it is not directly pointing towards the center of the cord. It is very important. So median or paramedian means it is towards the spinal cord, but it is not directly backward, but it is slightly away from the backward. So it is 5 o'clock, or it is between 6 to 7, or it is between 6 to 5. So it is not directly towards the spinal cord, but it is towards the spinal cord, but directly away from the center of the spinal cord. So it is called median or paramedial disc bulge. So it is very important that central, posterior, posterocentral, and median and paramedian, these are all towards the spinal cord, and it is very clear and it is very important while starting your treatment. And another one is posterolateral disc bulge. It is very important that the weakest area of your disc is the anterior portion of the disc, posterior lateral. So the weakest area of your disc is posterolateral. So posterolateral means it is very important that the disc bulge towards 5 o'clock, 5 to 4 o'clock, or it is what to 7 to 8 o'clock. Okay, so posterolateral disc bulge is towards, so in such cases, there will be nerve root compression. So that's why in common MRI, you can see posterolateral disc bulge with left or right radiating pain, exiting or traversing nerve root compression. So in case of posterolateral disc bulge, it is towards 8 o'clock position or towards the 4 o'clock position. That means it is away from the spinal cord, and it is mostly towards the lateral recess or neural foramen. So posterolateral is usually towards lateral recess or neural foramen, and it is somewhat safe compared to the posterior, central, posterocentral, median or paramedian disc bulge. And in this presentation, there will be more sciatica. In posterolateral disc bulge, there will be more sciatica. And in case of median, paramedial, central or paracentral disc bulge, sciatica symptoms are very less, and there will be more weakness, or there will be more back pain with lower limb weakness will be the prominent symptoms. Okay, so in posterolateral disc bulge, this will be usually towards 4 o'clock or 8 o'clock, and usually it is towards spinal, that neural foramina or lateral recess. In some cases, it is lateral disc bulge. Lateral disc bulge means it is towards 9 o'clock or it is towards 3 o'clock. So it is very important. With the terminology, you can assume the prognosis and the condition of the patient. You can see how it is happening. So you can see this is the disc bulge. You can see this is the nucleus, and outer annulus there will be a break. If it is bulging the whole area, that is called the diffuse disc bulge. And you can see it is a case. You can see this is a focal disc bulge, and you can say it is away from the spinal cord. Actually, it is away from the spinal cord. You can say it is towards the lateral recess and nerve root. You can see it is towards the lateral recess. So the patient may present with back pain with left radiating pain. You can see the lateral recess is compressed by the posterolateral disc bulge. Okay, and you can see the nerve root is crushed between the neural intervertebral foramina. So the presentation may be a severe case of left neural foramina, and it is ideal to take proper rest, 5-day complete rest, and you can start traction and our treatment. Okay, so this is the case of median, paramedian, and central, posterocentral towards the disc, and posterolateral towards the nerve root or neural lateral recess, and lateral towards the typical nerve root, exiting nerve root. Okay, so it is very important. You can see the presentation. Okay. So it is very important in case of disc bulge and prolapse and protrusion, disc bulge or prolapse or protrusion, you can treat it well with proper rest and our treatment. And in case of extrusion and sequestration, it is very important to rule out. Actually, below the L1, there not be any cord. So any treatment, any spine-related treatment, if you are starting your IP treatment, just to go through some investigation, like you ask some question like bowel urine incontinence, okay, any gait abnormalities, any saddle anesthesia. So he bowel urine incontinence and gait abnormality is very important while treating the extrusion and sequestration. If the questions are not or negative, that means you can successfully treated any case of extrusion or sequestration with caudal migration or cranial migration, whatever may be in the MRI, you can treat if the patient is clinically indicated. There will be no distal neurovascular deficit. You can see in some case sheet DNVD, distal neurovascular deficit. If there is no distal neurovascular deficit, you can treat the patient. Okay. Another case of sciatica, or it may be a piriformis syndrome. It is very interesting that one Ayurvedic doctor from Punjab visited last week in my OPD with a 3-year history of chronic back pain radiating to his both thigh. He's very, very tense because he's having 3 year during the final year exam. He started, he's having X-ray, he's having MRI report, which having mild disc bulge. Just clinically, he's having no sciatica actually, but he's having a back pain radiating to his both knee or both femur, and clinically he's having tight hamstring and he's having severe gluteal pain. And the past 3 year modern and Ayurvedic doctors from the different area diagnosed it as sciatica. And I just examined the patient and suggested hamstring stretching and a sitting of just half an hour, sitting of hamstring and gluteal stretch. Diagnosed it as a piriformis syndrome. Very simple. The piriformis muscle, which crosses the sciatic nerve, actually it is a case of piriformis syndrome. And yesterday is one picture from him. He's celebrating the Diwali in OT with a cake. His picture is that in his that DP. There's a picture that he's celebrating Diwali in his OT. Okay, so never miss a piriformis syndrome. It is very important that in piriformis syndrome there will be severe pain in the back, and more than that, there will be severe pain in the gluteus, especially if you are pressing the special area and the area of piriformis syndrome, because it is start from the sacrum and it end in the trochanter, greater trochanter. So area between sacrum and greater trochanter, you mark that area. If the patient is having special tenderness, deep tenderness, than the sciatica, and if the sciatic pain is aggravated with the pressure effect, that may be you have to rule out a piriformis syndrome and simply just do a hamstring stretching and a piriformis stretch. Patient feel better if you are doing a piriformis stretch for a 15 to 20 minutes program. It is very easy. And I just given Grita preparation to relieve the muscle. Just a muscle relaxation is enough for the treatment. And he just 1-day treatment. Actually, just given a stretching to his gluteus and hamstring. It was not a sciatica, but he's treated as Ayurvedic. Even he done that in the Kanyakumari. He done Ayurvedic treatment with Vasti, etc., etc., etc. Anything. Actually, it is not a sciatica. It was a simple case of piriformis syndrome. It is I think a 2 week back. Another case is a 43-year-old male with a severe pain in the gluteus, radiating to lower limb without any back pain and tenderness. And I suspected a piriformis syndrome and treated as a stretching, just to give a stretching and a simple medicine. And he's feel better in first few days, first 1 to 2 days. And again, the pain aggravated, and it is very, very difficult him to continue the sleep or sitting. And in the next day, again, after the piriformis stretching, patient become bad. And if patient is already having an X-ray, I suggested an emergency MRI, and it is having a severe extrusion with a severe spinal canal stenosis. So very important that if a patient is having severe back pain with a gluteus pain, it is very important. Patient with a sciatica presented more gluteal pain than radiating pain. You have to rule out piriformis syndrome. So any local tenderness or a deep tenderness over the piriformis area or the gluteal area, it is very important, because the gluteal area, it is very important for that Cauda Equina syndrome. It is very important for severe extrusion and sequestration. So back pain with the gluteal pain, especially if the pain is aggravating or a pressure effect, you have to rule out piriformis syndrome. If it is failed, the stretching, if the patient is not getting any relief with 1 to 2 days of piriformis stretching or hamstring stretching, definitely send the patient for MRI to rule out extrusion or sequestration. These are the two cases, the last 1 month, within last 1 month. One is 100% relief after 3 years of treatment. One is emergency surgery within 5 days. Okay, so it is very, very important that piriformis syndrome, it is very rare, but there may be a possibility of piriformis syndrome. So any patient with back pain and severe gluteal pain, you have to rule out severe extrusion because the area of S3, S4, S5, S1 and S2. S1 and S2, sorry, S2, S3 is related to your urinary system and S3, S4. So these are the area it is, you can see that dermatomes, S3, S4, F4, these are around the gluteus. So any area, pain and tenderness over the gluteus, which is maximum than the back pain, and with a less radiating bed or MREs are not suggestive of any other, it may be a piriformis syndrome. But any pain and tenderness which is more prominent in the gluteal area, rule out piriformis syndrome and severe case of extrusion with caudal migration or spinal canal stenosis. And second case, I suggested surgery and he is normal now, no problem. He is underwent surgery, he is now on rest. And this Punjabi Ayurvedic doctor, he is celebrating the Diwali. These are the same case, same presentation with a mild difference in diagnosis. Okay, it is very, very important in your clinical practice. And the most important area in your IP treatment, one is Cauda Equina syndrome and the compressive myelopathy. I can see what is Cauda Equina. It is very important that L1, L2, at the level of, below the level of L1, the spinal cord end, after that there will be only nerve root. So there are some area from L1 to L5. You can see all the lumbosacral nerve root are passing through the same area. It is called Cauda Equina. Because between the area of L1, below the area of L1, there will be no spinal cord, but that specific L1 to L5 area, there will be separate area through which the lumbosacral nerve passes together. So any abnormal growth or any abnormal compression in that specific area result in a Cauda Equina syndrome. This is very important. Why Cauda Equina syndrome is surgical? I have seen so many articles that Cauda Equina syndrome can be treated because I had a case of Cauda Equina syndrome. He's actually a bank manager from Wayanad. Now he is okay. He is free. He is working without any complaint. He is diagnosed as a Cauda Equina syndrome in MRI. So why Cauda Equina syndrome is clinically important? Every diagnose, every MRI diagnose, it is just an investigation. So what is your clinical diagnosis? So you correlate your MRI or investigation with your clinical presentation. If it is clinically indicated, just go for surgery. Because that patient with Cauda Equina syndrome, I suggested 3 months of rest and repeated MRI. The MRI was same. Patient is having a Cauda Equina syndrome even after 3 months, but clinical presentation was normal. And he's still working with 6 or 8 hours sitting in his bank. He's having no problem. Because why Cauda Equina is surgical? Only if it is clinically indicated. So this is a case of 57-year-old non-case of lymphoma, presented with acute weakness of this bilateral lower limb and gradually noted urine incontinence. But fecal flow was normal. It is very, very important in case of Cauda Equina syndrome. Urine incontinence are mostly affected. Okay, and the fecal flow was under control along with the numbness over the medial thigh and saddle anesthesia. Saddle area means it is the area around the perineum and the private area. So it is very important that patient having already lymphoma under treatment, acute weakness of the bilateral lower limb, and he's noted urine incontinence, but fecal flow was normal with numbness because he's not knowing while sitting over the toilet. He's feeling that there is nothing over that specific area. So he's feeling a saddle anesthesia in the inner thigh and the gluteal area with the urine incontinence and acute weakness of the back without a specific injury. And emergency attention by a neurosurgeon, send the patient to a neurosurgeon. The very next day morning, done surgery, 95 to 100% relief just after waking from the anesthesia. It is the most important area. If the Cauda equina syndrome is clinically indicated, if the surgery is late by 48 hours, the bowel urine incontinence cannot be corrected even after surgery. It is very, very important. If the Cauda equina syndrome is clinically indicated, not treated within 48 hours, the bowel urine incontinence cannot be corrected even after surgery. So the very next day after surgery, with a waking from with a normalcy from the anesthesia, patient feel 95 to 100, no weakness in the back, no normal flow. Okay, no numbness or saddle anesthesia. It is a typical case from Thrissur. Okay, the patient is not more, actually is like lymphoma patient. Okay, so very next day, the importance is very next day surgery, 95 to 100% relief. If the surgery is delayed by 1 to 2 weeks, the bowel urine incontinence cannot be corrected even after surgery. So if the Cauda equina syndrome is clinically indicated, not in MRA, if it is clinically indicated, go for surgery. And Cauda equina syndrome is actually surgical, not treatable, only if it is clinically indicated. That is surgical if it is clinically indicated. So you can see it. So what are the questions to be asked? It is very important. If any patient came to our OPD with a lower limb weakness, okay, any back pain, any patient. So these are the questions to be asked. Whether there is any pain or weakness or heaviness, rather than bilateral sciatic radiating pain, there will be weakness and heaviness in the lower back. It is very important. It may be unilateral and rarely, it is bilateral and rarely unilateral, and weakness and heaviness. So the first question will be whether there will be any weakness or heaviness in the lower limb, especially weakness in the lower limb. It is the first question. Every back pain, you have to ask the patient for weakness in the lower limb. And perineal sensory deficit. It is very important. What is saddle means that sitting area over the horse. That is a saddle. So that specific area, inner thigh, and the specific perineal area, there will be a sensory abnormality. There may be paresthesia or maybe an anesthesia. It is called saddle anesthesia. So just ask the patient for any sensory, any abnormality over that perineal area. It is the second question. And the third question will be any altered bladder or bowel function. It is very important, and it will be a painless retention. If the urine is retention, there will be severe pain in the lower abdomen, and it is very important that there will be painless retention or maybe overflow incontinence in the later stage. So altered bladder function with a painless dysfunction, painless retention, and loss of anal tone. That is, there may be bowel dysfunction. And in male, there may be erectile dysfunction. So the question should be weakness of the lower limb. If there any weakness of lower bilateral lower limb, any perineal area, especially saddle anesthesia, any altered bowel urine issues, definitely send the patient for an emergency MRI. Not an MRI, it should be an emergency MRI. Just mention that MRI lumbar spine with whole spine screening, and especially mention it is an emergency MRI to rule out a Cauda equina syndrome. So these are the questions to be asked. So these are the conditions like spinal canal stenosis. So what is the important? I have seen the patients from Kerala, their doctors are treating severe spinal canal stenosis. So any patient with spinal canal stenosis, there will be a possible Cauda equina syndrome in the future. So definitely during the treatment, you have to reduce the body weight first, and you have to select specific exercise protocol for the patient to prevent a Cauda equina syndrome. And you have to inform the possible Cauda equina syndrome and mention the patient or educate the patient that if he is developing any lower limb weakness, any saddle anesthesia, any bowel urine incontinence, just go to the doctor emergency for preventing paraplegia. It is very, very important. You have to educate your patient, even the patient is under spinal canal stenosis, not a Cauda equina syndrome. So every back pain patient, before starting your treatment, educate the patient that if the patient develop any Cauda equina syndrome, like patient develop any lower limb weakness with bowel bladder incontinence and saddle anesthesia, it is a complicated one, then just go to the concerned doctor, maybe an Ayurveda or allopathy anyway. So these complications should be educated for the patient before starting every treatment. So by spinal canal stenosis, especially if the spinal canal diameter is below 10, it is called stenosis. So from 7 to 9, it is mild. From 5 mm to 7 mm, it is moderate. Below 5 mm it is surgical. So stenosis, degenerative disc disease, ankylosing spondylitis, congenital spina bifida, and any abnormal growth. Okay, any infection. Oh, so they can be diagnosed with X-ray and MRI. Just send the patient for further neurological evaluation. So these are the conditions: bilateral leg pain after back pain, especially weakness, loss of sensation in the private area and the upper thigh, pain in one or both leg, and sensory motor loss in the lower extremity. And in male, it may be having erectile dysfunction and the saddle anesthesia. So these are the questions and these are the presentations by the patient. So there will be neurogenic bladder dysfunction. So very important is lower limb weakness, saddle anesthesia, and bowel urine incontinence. These are the three questions, important questions to be asked by the doctor for before treating any patient, and also to educate any patient if the patient is having severe spinal canal stenosis or CVL presentation. Okay, and another case. So it is very important that the Cauda Equina syndrome is the most complicated and 100% surgical condition mentioned in modern orthopedics only if it is clinically indicated. So in MRI, if it is suggested as a Cauda Equina syndrome, but the patient is having no lower limb weakness, no saddle anesthesia, no bowel urine incontinence, you can treat the patient with the safety measures, with a clear education of the patient. Okay, if it is clinically indicated, just go for surgery within 48 hours. Okay, and another important condition which is 100% surgical is cervical myelopathy. There are so many conditions like upper motor neuron lesions and that transverse myelitis or another growth. So many conditions that induce myelopathy. So in case of normal disc-related pathology, it is called compressive myelopathy. This is one of my patients. She is 46. She's an unmarried lady presented with a severe case of that myelopathy. And you can see the report. I just see the report. You can see severely at C4, C5 with compressive myelopathy. You can see the MRI report itself. And you can see the spinal canal diameter is just 3.5 mm. At C3, C4 level, it is 6. C4, C5, it is 3.5. So it is very, very important that the patient is having this report. I suggested emergency surgery. Unfortunately, treated by eminent Ayurvedic doctor with a traditional background from Calicut. And now she is in quadriplegia. During the Ayurvedic treatment, she got paralyzed. A typical case of quadriplegia. It is actually a big mistake from the part of the doctor. He's a qualified BMS doctor with a traditional background. And after that, he visited me. The patient bystander visited me. Can you do anything? Because before referring the patient, I educate the patient for an half an hour minimum with the demo of that specific spinal column. Even after this much education, patient went for Ayurvedic treatment, and the doctor assured that he can treat the cases successfully without any complication. And during the treatment, now she is having some weakness, just weakness in the right hand, and lower left hand and lower limb are completely paralyzed. So never ever treat a patient with a clinical presentation. So it is by a qualified doctor in Kerala. Okay. And another case of ex-military man, she's actually a father of an Ayurvedic doctor, is my friend. An online consultation with a clinical presentation, and it was a compressive myelopathy, and I suggested surgery. But actually, he's an army man. He's not receiving anything from outside, so he's not willing for surgery, and he developed quadriplegia. He's just walking down, just a fall, and the diagnosis diagnosis from the hospital was traumatic quadriplegia. I suggested surgery before 1 month of the fall. If the patient is, and it is very important that any paraplegia in Cauda syndrome and any quadriplegia in cervical myelopathy is untreatable, irrecoverable quadriplegia and paraplegia. In other conditions of stroke, etc., we can treat the quadriplegia or paraplegia. If the nerve conditions are resolving, the patient may get better. There may be some strength, so weakness may be relieved. But in case of quadriplegia, in myelopathy and in paraplegia, in that spinal, that Cauda syndrome, it is untreatable, it is irrecoverable, it is a permanent defect. And you see that patient of 46 years, he's having a permanent quadriplegia, and this ex-military man is also having a permanent quadriplegia, even though I suggested surgery. It is not my case, but it is a normal case in everywhere. Just refer the patient if it is clinically indicated. And another case, 7th day of physio, I suggested surgery, is from Vadagara, Kozhikode district itself. So I strongly suggested never go for any physiotherapy, just go for a surgery. And they adopted physiotherapy with the he adopted physiotherapy by advice from a physio, and the 7th day of physiotherapy, he get paralyzed. So these are my personal experience, and it is irrecoverable damage. You can't treat any quadriplegia or paraplegia if it is Cauda syndrome, if it is compressive myelopathy. Only if it is clinically indicated, just refer the patient. So another case, it is very, 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 you can see the case, just you can see, there is no term that there is having compressive myelopathy. It is very important. 34-year-old male with bilateral upper limb radiculopathy, with lower limb unstable gait, positive Babinski sign, Hoffman reflex, bowel urine incontinence, and erectile dysfunction. Also, MRI, just a cord ischemia. You can see the report. You can see that prolapse causing moderate spinal cord. You can see the cord ischemia, C5, C6 level, and you can see the MRI report. And you can see this is the one case. This is the case report from an Ayurvedic college and written by that house surgeon. It is very clearly, and it is very clear that this patient is treated knowingly that patient is clinically indicated. It is just, you can see the presentation numbness and weakness, hand, thigh, and foot since 2 years. You just note that patient is having cervical issue. So any patient with cervical issue is developing weakness in the lower limb. That means it is a cord compression. Even though in MRI it is mentioned that it is just a cord ischemia. You can see the presenting complaint. Numbness, weakness of the hand. Okay, it's okay. Thigh, foot since 2 years. The second one is loss of balance while walking. That is a typical case of gait abnormality, loss of balance while walking. Then notice a slight weakness, bilateral hand while doing daily activities. That is, fine motor movement activities are affected. So there is gait abnormality, gait of the patient is affected. Daily activities, there will be slight weakness of the hand. That means fine motor movements are affected. And you can see numbness also developed between thigh and foot. Very, very important. It is saddle anesthesia in the upper thigh. And he developed a loss of balance while walking and burning sensation of the lower bone. So developed a loss of balance while walking. And it is very pathetic that the academicians are teaching this pathology or this condition to the house surgeons or coming Ayurvedic doctors, that this myelopathies can be treated with Ayurveda, because this is the presenting complaint written by an house surgeon. It is so pathetic. That's why I am putting this slide. It is because it is knowingly they treated cervical myelopathy. Actually, cervical myelopathy, I had a patient now. Even now, I have a patient from Manjeri. She's a lady, and her daughter is having a scoliosis. Both are under my treatment. She's having typical case of myelopathy in MRI, but not clinically any presentation. She's under treatment. She's okay, no problem. But even though MRI is not suggestive of myelopathy, but MRI you can see a cord ischemia. But typical presentation of myelopathy, that is weakness of the both hand while doing daily activities. That means fine motor movements are affected. It is upper limb, but bilateral thigh numbness, that means saddle anesthesia. You can see loss of balance while walking. This is a gait abnormality. And advised surgery, but he was not willing for it as there was no relief. So the why they adopted Ayurvedic treatment, this is not willing. Okay, the neurosurgeon suggested surgery, but there was no relief with treatment. The Ayurveda college, the doctor decided to do IP treatment with Ayurveda. I examined again the patient. This was a typical case of, you can see the clonus, you can see the Babinski sign, you can see the Hoffman's reflex, you can see the bowel bladder. I suggested surgery, even though I suggested he is not willing for surgery. Daily he's singing patient actually. I suggested, but he's not willing. He's a singing patient actually. We expect a quadriplegia in the recent time. Even though he is not willing for surgery, we never accept a miracle if the patient is clinically indicated. So it is a case sheet. It is an eye-opening case sheet for all academicians, all doctors or practitioners with a clear case of malpractice. So it is, everyone should know this is a case. I'm not mentioning any colleges, any authorities. I had name and all authority, just case the clinical presentation written by a house surgeon. It is very important. It is very important. It is very, very, very important. So these are the MRI of that patient. You can see typical case of cord compression. So even though patient is having not MRI report with a clinical picture of severe cord compression, better to send the patient for surgery, even though it is indicated. If not indicated, this much cord compression means it is ideal to do surgery. Okay, even though it is not indicated with the MRI picture, it is ideal to do surgery, or if the reason there may be a possible paralysis for the patient. So what is the cervical myelopathy? It is very important. Clinically, the patient start bilateral neck pain radiating to both hands. It may be the initial presentation, normal neck pain and radiating pain. That is a cervical brachioneuralgia. As in sciatica in the lower limb, it is cervical brachioneuralgia. So start with normal neck pain with radiating pain, and gradually numbness and paresthesia of the lower hand. It is very important. And hand clumsiness. It is very, very important. That means the fine motor movements are affected. So a patient with a chronic cervical pain, neck pain with bilateral radiating pain, if started numbness and paresthesia with hand clumsiness, especially fine motor movements are affected. So the first question to rule out a cervical cord compression, not a myelopathy, the cord compression is ask the patient to do buttoning. It is very simple. Ask the patient to write his name on that paper. You just remove the button. Just ask the patient to rebutton, or buttoning. Ask the patient to write the name. Okay, ask the patient to take a pen or something which is very small. It's a simple test to diagnose a cord compression. Okay, so numbness and paresthesia of the upper limb after neck pain with radiating pain, and if the patient is having a clumsiness in the hand or fine motor movements affected, that means buttoning is affected, writing using a pen is affected, or something taking as a food, a small thing as a food is affected, means the patient is having a cord compression. So very easy that patient finger escape sign. Ask the patient to do that finger release sign. Very, very simple test. If patient is having any myelopathy or compression, there will be reduced speed of the finger escape or finger release. So we ask the patient to do that finger escape or release sign and do the abduction. To do the abduction of your finger escape and finger release sign. You can see the Hoffman sign. Just tap over the middle finger. You can see the adduction and flexion of the forefinger with the adduction of the thumb. It is a simple test. So these tests are clinically, but very easy to diagnose a cord compression means ask the patient to do buttoning. It is a simple test. And every case of lower limb weakness, usually bilateral sciatica or some patient bilateral sciatica may develop weakness, But it is very important that in case of cervical pathology, mostly they develop lower limb weakness than sciatic pathology, because Cauda equina syndromes are very rare than cervical myelopathy. So if the patient is presented with lower limb weakness, just rule out cervical cord compression than sciatica or Cauda equina syndrome. Because I have seen so many patients, so many doctors are sending MRI. If the patient is presented with a lower limb weakness, MRI lumbar spine. Actually, it was a cervical myelopathy and the lumbar reports were normal. Okay, so any lower limb weakness, it may be a cervical issue, it may be a lower limb issue, anything, any lower limb weakness, it is ideal to the whole spine MRI. MRI cervical spine with lumbar screening. It is the ideal MRI if the patient is having any lower limb weakness. Okay, so just hand clumsiness or fine motor movements, you just test in your OPD. Ask the patient to write his name or a buttoning. Okay, then clinically, if the patient is walking, it is very important. Shortened step length. The speed is reduced. It is very easy. If you are coming to your OPD, you just watch the patient. Shortened step length shows short step, reduced gait velocity. So speed is reduced, step length is reduced, and widened step length. Step width is widened, and reduced angle joint extension during the walking. You can watch the patient, you can diagnose the patient with a simple walking. You ask the patient to walk. Usually he needs a support for walking. So these are the simple tests for cervical myelopathy. So in such cases, you can see diminished reflexes. So for clinically diagnosing, if the patient is presented with that fine motor movements like buttoning, just to do a Babinski sign. It is very, very important to rule out a cord compression. So every back pain patient just do a Babinski sign to rule out any abnormal cord pathology. So Babinski sign will be positive, and the clonic, and there are some doubt for doctors whether it is positive or negative. This is partially positive. I have seen some case sheet that the doctors are writing partially positive. There not be a no partial or yes or no. This is just one yes or no. Is this positive or negative? If it is positive Babinski test, there will be a fanning of the toes. If it is negative, there will be flexion of the toes. There not be any partial positive or partial negative. If there is a cord compression, there will be definite fanning of the finger. There is a not partial fanning or partial flexion. It will be either positive or negative. And there will be definite urine and bowel incontinence. It is very important that in case of that Cauda equina syndrome, the bowel urine incontinence are early developed bowel cord incontinence. It is very important. Early urine and bowel incontinence features are seen in that Cauda equina syndrome. But in case of that cervical myelopathy, the bowel urine incontinence are in the late stage. Initially, they start that fine motor movements are affected, and late stages, it may develop bowel or urine incontinence. So any compressive myelopathy, any cord compressive myelopathy with bowel urine incontinence means it is a chronic condition. You have to treat it surgically. And in case of Cauda equina syndrome, it is early developed bowel urine incontinence. And in case of compressive myelopathy, it is late developed. So in both cases, with the positive Babinski sign and sustained clonus or bowel urine incontinence with fine motor movement. So these are the questions to be asked. One is any fine motor movements is affected, that hand clumsiness is the first question. Second one is any bowel urine issues. And third one is clinically patient is having any weakness, especially in the lower limb. And fourth one is if the Babinski sign is positive. If the Babinski sign is negative, means there is no cord-related issues. So this is a simple test you have to do in your clinic to rule out further complication. And in case of pediatric spine injuries, it is very, very important because I think 2 years back, Ramzan, first day, on the Eid, very early morning, 6 o'clock, I got a patient with cervical injury. The patient was just a 2-year-old patient with an unstable head. And that day, usually doctors are on leave, mostly because it is a Eid day. Patient is having severe, patient is just 2 years with unstable. The patient is just sitting, patient is playing, but neck is unstable. So how to diagnose a spine-related injury in children? It is very, very important. So any fracture or any injury, it is very important. So in children, any spine-related injury, any fracture, any fall from height, any RTA, posterior midline cervical tenderness, it is the ideal criteria. Most important, posterior cervical midline tenderness. So you just tender that specific area. Posterior midline cervical tenderness is the most important criteria for assessing any cervical issues. And the feeling of an intoxication, just not the patient, not the children. If any feeling of intoxication, okay, it may indicate an abnormal injury. And level of alertness, you just speak with the parents, or just note the patient that the level of alertness is okay. If the patient is having a level of alertness is okay, that means it is not a problem. But if the level of alertness is unstable, that may be there may be a negative effect, and there may be, if any, focal deficit. Focal deficit means the patient any focal neurological deficit. So any issues, patient is having cervical tenderness, posterior midline cervical tenderness, any feeling of intoxication to the patient, any painful distracting injuries, any abnormal shape difference, any level of alertness from the normal, with the discussion of the patients and by examining the children, and any focal neurological deficit, definitely send the patient. And in that cases, it is very important that if the patient is playing normally, if the patient is walking normally, it never exclude any spinal cord injury or any spine related fracture. It is very important in case of children. If the patient is that patient is playing, if patient is walking, if children is walking, is playing, it never exclude any complication, because the spinal cord can elongate up to 2 mm without any complication. So any posterior midline cervical tenderness is there, just refer the patient, even though other parameters are normal. Okay, so playing or walking or sitting is not a criteria to exclude the so-called spine injury. So in case of children, it is very important posterior midline cervical tenderness and the level of alertness, any feeling of intoxication, and if it is head-related pathology like head injury, 2 or more episodes of vomiting is there. There is a definite CT report should be there. Okay, so any case of 2 or more episodes of vomiting, send the patient to a neurosurgeon or send the patient for a CT scan. So after X-ray of spine, CT scan is the ideal option, not an MRI, for this spinal canal injury or spinal cord injury. It is very, very important. After X-ray, CT scan is the ideal option. So any patient with midline spine tenderness, maybe a cervical or anything, or level of alertness or intoxication with a focal neurological deficit. So at that patient, the patient is actually having, patient is playing normally, the patient is having just crying and with the unstable gaze, just refer the patient, because there is a midline cervical tenderness with unstable neck. Okay, but even though the neck is unstable, patient is playing well, and not playing well and walking well is not a criteria. As it is a complicated one, just refer the patient. So posterior midline cervical tenderness, a feeling of abnormal alertness with a focal deficit, always send the patient to an expert opinion. Another one is a case discussed by a medical officer from ISM department. Okay, it was 45-year-old male with a history of RTA with a severe upper back pain, lower limb weakness, with no urination after 9 hours. On neuroconsultation, diagnosed T7 fracture and advised an emergency surgery. And for the opinion, she called, I suggested surgery, but it is, you can see an Ayurveda college, they suggested a conservative surgery, and we will treat it by conservative if surgery don't bring the patient to our college. This is the opinion from our faculties. So why it is surgical? It is very important that there are so many fractures in spine. It may be a wedge fracture, it may be a compression fracture, it may be a burst fracture. If it is stable, if it is neurologically stable, never send the patient for surgery. You can treat very well every case. I will show some issues. But the patient, the presentation was with no urination last 9 hours, with the weakness of the lower limb, So it is a surgical indication in case of spine fractures. So the opinion, the similar word from the authority of our teachers, teaching authority. So it is very, very pathetic that any patient with neurological deficit, distal neurovascular deficit, in OPD we can see the prescription, no DNVD. That means there is no distal neurovascular deficit. So in case of any fracture, any injury to the spine, local tenderness over the spine should be noted. And along that, there are 10 reflexes you have to check. It is very important. First one is C5, cervical, fifth cervical for shoulder, especially for deltoid muscle, C5 for abduction of the deltoid. You have to check the deltoid muscle function, first one. And second one, C6. Okay, C6, it is for wrist extension. So you just ask the patient to abduct the shoulder. It is test for C5. Wrist extension and elbow flexion, it is C6. You just ask the patient for wrist extension. Okay, and third one, C7. It is elbow extension. So it is related to triceps, C7. Okay, and C8. It is very important, C8. C8 is finger flexion. Okay, and T1, finger abduction. Okay, and L2, hip flexion. And L3, L4, knee extension. And L4, ankle dorsiflexion. And L5, toe extension, that is EHL weakness in L5 radiculopathy. And S1, angle plantar flexion. These are the 10 important nerve reflexes, that is motor reflexes, you have to check in any patient with a spinal injury. Even though MRI is suggestive of normal function, because MRI is just a test. If you are taking MRI, it is a static one, it is not a dynamic one. So C5, C6, C7, C8, T1, and L2, L3, L4, L5, S1, and S2. These are the 10 motor reflexes you have to check. Okay, so there are deltoid is there are wrist extension is there, and their elbow extensions is there. Okay, and finger flexions are there, finger abduction is there, hip flexion is there, and knee extension is there, ankle dorsiflexion, and EHL weakness or toe extension and plantar flexion. These are the 10 area to be noted in every. If it is normal, even though the surgery, the MRI is suggestive of surgery or severe retropulsion, anything, just treat the patient, because the clinical presentations are most relevant than any other presentation. And after that, if there are any thoracic, because I have already told the patient with numbness around the umbilicus. So it is very important in case of any cord abnormality that growth. Okay, and any other cases, you check for umbilical reflexes. From the four quadrant, just towards the umbilicus, you check for the abdominal reflex towards the umbilicus. So in case of thoracic spine injury, in case of any growth in the thoracic area, there is a loss of abdominal reflex. There are another condition like obesity, pregnancy, there will be loss of abdominal reflex. But in any spine cases, check for abdominal reflex. In acute case with the coma, or in acute case, it is very important that bulbocavernous reflexes. It is in private area, in penis and clitoris. If you are checking the bulbocavernous reflex to rule out a spinal shock. If the patient is in spinal shock, the reflexes will be absent. And after getting the reflexes, only that we can assume the prognosis. So these 10 reflexes, the localized tenderness, these 10 motor reflexes, then abdominal reflexes, these bulbocavernous reflexes in penis and clitoris. These are the important tests to rule out the possible complication in spine disorder, especially spine injury or RTA. Okay, then how to assess a fracture? These are the conditions for assessing a fracture. So which are the conditions you can treat safely without any complication? Even though you can have a fracture, you have to check all these assessments. But you can see, this is a case of, you can see a vertebrae, anterior column. It is imaginary column, anterior column, middle column, and posterior column. You can see the picture. And this anterior column, like that, there will be anterior longitudinal ligament, which connecting the all anterior aspect of, you can see the red line here. It is the anterior longitudinal ligament. What the importance of longitudinal ligament is the stability of the spine. So there is anterior longitudinal ligament, and you can see the annulus. This blue color, you can see the annulus of the vertebrae, intervertebral disc, and there is 2/3 of the vertebral column, vertebral body. So it is included in the anterior column of the spine, and it is the safest area. Usually in our OPD, we are getting wedge fracture, which are usually under anterior column. So it include anterior longitudinal ligament, which connect all the anterior body and the vertebral body, which are anterior 2/3, and the third one is the annulus of the anterior disc. So it is the anterior column, and it is very important that any fracture of the anterior column are 100% conservative. It is very important because it is not related to any neurological structures. So anterior spinal fractures are 100% conservative. Okay, and second one, middle column, it include posterior 1/3 of the vertebral body, and you can see this area, this line, this imaginary line, through which that area behind this vertebral column, there is the spinal canal, and inside the spinal canal, that means anterior wall of the spinal canal is formed by posterior longitudinal ligament. That's why in MRI, posterior longitudinal ligament hypertrophy means it induces spinal canal stenosis. So in this line, you can see this line. You can see this line through same line as there is posterior, just like the anterior longitudinal ligament. It is outside the vertebral body. You can see the posterior longitudinal ligament, which is inside the spinal canal. So any injury, any buckling, any abnormal growth from the outside, it affects the spinal cord. So it is very important. So in middle column fracture, middle column fractures are surgical only if the posterior longitudinal ligament is affected. So anterior column is not surgical, it is 100% conservative. Middle column is 100% conservative only if the posterior longitudinal ligament, rather than the posterior longitudinal ligament or the posterior vertebral area, vertebral body is stable. Okay, so there may be a fracture in the middle column, but it is not surgical if the posterior vertebrae is stable. So if the posterior vertebral height is maintained even after injury, it is non-surgical. That means if there is any alteration in the posterior height of the vertebrae, it is surgical. So anterior column is 100% conservative. Middle column is conservative only if even after the injury, the posterior vertebral height is maintained. That means posterior vertebral height and posterior longitudinal ligament is intact even after surgery, even after injury. That means it is conservative. After injury, if the posterior vertebral height is reduced or there is an injury to the posterior longitudinal ligament, that means it is surgical, because just behind the posterior vertebral area, there is spinal cord, and the anterior wall of the spinal canal is posterior longitudinal ligament. So any buckling or any hypertrophy, any injury to posterior longitudinal ligament or posterior margin of the vertebral body, which affect the curvature or the diameter of the spinal canal, in turn it induces spinal canal stenosis or cord compression. And in posterior column, almost all the injuries are surgical except injury to that spinous process or injury to that transverse process. So any injury to that transverse process, any injury to the spinous process are not surgical. All other fractures like lamina fracture or any fracture to the facet joint, because any fracture to the facet joint, it may affect the spinal canals and it also affect the neural foramina. If it is medial to the spinal canal, if the facet joint fracture is towards the medial side, it affects the neural foramina. If it is if it is towards the column, it affects the spinal canal diameter. So anterior vertebral column, anterior column is always conservative, and middle column is always conservative only if the posterior vertebral height is maintained along with a normal posterior longitudinal ligament. And the posterior columns are always surgical only that transverse and spinal process fractures are conservative. So you can see some fractures like wedge fracture. So it is very important that except in T11 and T12, all the vertebrae having normal anterior height and normal posterior height. So anterior vertebral height and normal vertebral height are equal in all vertebrae except in T11 and T12. So any abnormality in the vertebral height, especially less than 3 mm from the posterior side, it can be considered as wedge fracture. You can see a wedge fracture here, posterior vertebral height here, anterior vertebral height is reduced. So it is a wedge fracture. Okay, and another one is a burst fracture. That means it is splitted into so many pieces. So it is very important that in case of burst fracture, even though it is normally in X-ray, send the patient for a CT scan with a 3D reconstruction view. Any case of burst fracture, even though X-ray found to be normal, send to the patient for a CT scan to rule out any other complication. Okay, so there are wedge fracture and there are compression fracture. It is an axial compression. For compression fracture, it is due to axial compression. For wedge fracture, it is due to flexion distraction. And burst fracture, it is usually due to extension retraction. Okay, so a spine fracture assessment, it is very important. Distal neurovascular deficit with motor reflex abdominal. So can you see a patient? You can see the anterior vertebral height is reduced and you can see the vertebrae is displaced almost posteriorly. That means the posterior vertebral body is residing inside the spinal canal. This is one X-ray. And another one, you can see a anterior vertebral area, which are not specific actually, which is a diffuse borderline. This is not a normal borderline, but a patient is having severe back pain after a fall, but patient is having no definite margin of the vertebral body. Actually, it is a pathological fracture. With a simple fall, patient got a severe spine fracture. It is a pathological fracture. Actually, it was a tuberculosis. Okay, so you can see another patient. So this is the one of the X-ray. You can see this is a base fracture. Base fracture means a fracture. This is getting burst or several pieces. You can see both MRI. You can see the fracture fragment, the posterior border, which is protruded back into the spinal canal. You can see the MRI. This is spinal cord. You can see this is the multiple fracture. It is protruded, which is displaced back into spinal. The term displacement to back means it is called the retropulsion. So any retropulsion of the fragment toward the spinal cord, it is ideal to do surgery. So what is the role of surgery in spine fracture? Because the normal duration for spinal fracture treatment is minimum 90 days, minimum 3 months or 12 weeks. If the patient is diabetic, if the patient is above the age of 55 or 60, if the patient is having any other life disorders, the patient may develop severe muscle weakness or severe bed sore or such complication if we are immobilizing the patient for 3 months. And if you are doing a surgery, after 15 days of surgery, you can have sitting for your daily activities. It is very important. Even after spine surgery, especially for fracture, if you are stabilizing the fracture with the surgery, after 15 days, you can start physiotherapy. And in case of hip fracture, I have seen the patient with the hip fracture. We are sitting the patient after the next day of the rounds. Okay, very next day, you can sit the patient with a hemiarthroplasty. We can sit the patient after 2 weeks of the surgery. If it is non-surgical, if you are treated in non-surgical way, we have to immobilize the patient for 3 months with a urinary catheter. Okay, it is very complicated, very crucial. In case of femur fracture, there may be possible that fat embolism and death. It is I have confirmed the death patient with that hip fracture, especially that femur fracture. So it is ideal if the patient is having a retropulsion, even though radiologically normal, even though neurologically normal with retropulsion. If the patient is young, it is ideal to do surgery. Even though patient is having no neurological deficit, with retropulsion, it is ideal to go for surgery for early stabilization. If the patient is having above 55 to 60, without neurological issues, neurological deficit, You can treat conservatively, but there may be a possible bed sore or muscle weakness. That means if the patient was physiologically or physically normal before the fracture, you can have surgery. If a bedridden patient, because I have seen in we are visiting palliative. We have palliative unit here. We are visiting regularly in palliative care. So we have seen so many patients with the humerus fracture or spine fracture just a fall because they are osteoporotic actually. So if the patient is bedridden with a spine fracture or a hip fracture, send the patient for conservative treatment. Otherwise, any retropulsion you have to treat with surgery. Okay. Then you can see some investigation. You can see this picture. This is a lateral view. You can see this the transverse section of the the vertebral, the spinal canal. Actually, it is occluded completely by the vertebral body. We can see it is the patient which is completely occluded by the vertebral. It is a CT scan report. Actually, it is a small piece in lateral view. You can see it is completely occluded by that. So it is 100% surgical. You can see some cases with a retropulsion. One of my patient, it is a pathological. You can see the wedge fracture here. You can see burst fracture here. You can see the compression fracture in the same patient because the patient is a osteoporotic one. And another patient you can see with the fracture, but it is not related to spine and it is stable actually. You can treat this second case as conservative and you can treat this case as surgical. So because it is causing possible paralysis or quadriplegia. So it is conservative because it is not affecting the spinal canal and the posterior column is almost stable. It is unstable and you can treat it surgically. And the same, you can see the normal fracture. Okay, background is a wedge fracture clinically. You can see the wedge fracture. Okay, so if they are clinically not indicated, just give a thoracolumbar brace or a Taylor brace for 3 months. It is ideal to use Taylor brace because it is anterior spinal hyperextension brace. Okay, so the last area, that is spinal abnormalities. It is the last area, just 10 or 15 minutes we can stop. Okay, so this is one of the case which is misdiagnosed and treated as sciatica. Treated as actually it is a case treated as scoliosis. You can see the patient, you can see the X-ray without any scoliosis. It's a normal X-ray. But actually it is a case of untreated congenital hip dislocation. Okay, it is an untreated congenital hip dislocation, but it is treated. She is just 36-year-old lady. It is untreated and treated as sciatica or scoliosis from Ayurvedic institutions. And actually she is having limping. Okay, so actually how to differentiate scoliosis clinically? So these are so there are two types of scoliosis. One is structural scoliosis and another one is postural scoliosis. It is very important to check for postural scoliosis. One is short leg. It is very important if the patient with a short leg, how to differentiate short leg with the original scoliosis. Just ask the patient to sit over a table. If his hip is stabilized, there will not be any scoliosis. So if it is due to a short leg, ask the patient to climb over a table, sit over a table, there will not be any scoliosis of the spine because the scoliosis is basically due to the short leg. One. And second one is it is habitual. It is habitual. It is corrected by exercise protocol alone. And in case of sciatic scoliosis, it is due to severe nerve compression. You can treat the sciatic scoliosis only after subsiding the root compression. So short leg is there, habitual is there, sciatic is there. And the second one is structural scoliosis. It is the most important one, structural scoliosis. And it can be clinically tested. It's a very simple test. You can diagnose structural scoliosis. It is called the Adams test. And the X-ray is very important. Full length PA view, that is erect X-ray of full spine in PA and lateral view, including the iliac crest. It is very important. PA and lateral, not AP lateral. PA and lateral is the ideal view with erect standing. Full length PA lateral view of whole spine with erect standing is the ideal X-ray for diagnosing a scoliosis. So it is a case of Adams test. Usually, if you are asked the patient and you just not the patient, or you just look by sitting at the level of the back. You have to sit at the level of the back and watch for the curvature. You can see the normal curvature. You can see an abnormal curvature. Okay, this is one of my patient. You can see how to do that. You can see. Can you see the patient? This is just ask the patient to do that Adams test, and you can see there is a dome-shaped abnormality. This right side is like this, and left side is dome-shaped. Just do this Adams test. You can see the curvature difference. Okay, so simply just view, just look from your the eye should be at the level of the back, and you just look into the dome-shaped difference of the upper area. So this is a simple test for diagnosing a structural scoliosis which need proper treatment. Okay, you can see the difference while waking up. Okay. So clinically, what is research sign? These are two terminologies like research sign. That is the iliac apophysis that start ossifying shortly after puberty. But it is very difficult. Usually, if you are confident in X-ray, it is easy to do check for a research sign. But clinically, it is important that if a patient is above the age of 20 or 21, after the puberty, means after age of 20 to 21, there will not be any further development of the scoliosis. So after the age of 20 or 21, there will not be any further exaggeration or development of the scoliosis. So it is very important to assess the age of the patient, concept of the patient, and curvature of the patient, and to assess the prognosis. So after 20, there not be any further progression of the disease. So it is very important to treat the patient till 20. Okay, see, this is the research, and you can see type 1. So, and there are another term, this is called Cobb's angle. It is very important to measure the Cobb's angle, that we are measuring the deviated vertebrae, upper and lower, uppermost and lowermost deviated vertebrae, and we are measuring the Cobb's angle. It is very important that if the Cobb's angle is less than 20, the scoliosis will be resolved by itself. It is very important. If it is below 20, means it is resolved by itself. If it between 20 to 30, you have to use brace. You have to use that scoliosis brace. If it is up to 40, you can treat the patient. You can treat the patient between 20 to 30 degree of Cobb's angle. And after 40, it is ideal to do surgery. It is very important if the Cobb's angle. So if you are treating a patient with a scoliosis, send the patient for an MRI, and you ask the radiologist to specially mention the Cobb's angle and the research sign. But in some radiologists are not willing to write the Cobb's angle because the Cobb's angles are measuring using the X-ray. Okay, so if the Cobb's angle is below 20, it is resolving by itself. If between 20 to 30, you have to use the brace, and between 20 to 40, you can start your treatment. And if it is after 20, never treat any patient because it is 100% surgical. Because I have seen so many patients are treating every year with Ayurvedic treatment, even though their Cobb's angles are 47 to 50. It is non-surgical, not surgical. It is actually 100% surgical. We can write, because I have seen one of my patient is from Alappuzha, referred by one of my senior doctor, and I suggested you can see the Cobb's angle, which is measuring 47 degree. So it is ideal to write MRI and specially mention the Cobb's angle and research sign. You can see this MRI, the Cobb's angle measures 47 degree, means it is surgical. Never treat the patient, never treat the patient with medicine, with IP treatment. Just send the patient for surgery to an expert. You can see the angle is 85. It is surgical. So any angle above 40, Cobb's angle above 47, 40 is surgical. So I have seen some more patients, they are having more degree than 40, and they are treating every year with Ayurvedic treatment without any improvement, with a more expenses. So if it is, just mention that Cobb's angle in MRI, if it is above 47, and it is very important that I have seen so many cases from the authorities of Ayurveda, from the authorities of qualified doctors. They are giving ad in their Facebook or Instagram, or their clinic, their institution, their college, or any private personal blog. They are claiming that I am treating scoliosis. Before treating and after treating, they are picturizing the position of the patient. And it is very pathetic, because we are a scientific community and we have to assess the scoliosis, whether it is progressive or whether it is positive, with the possible corpse angle. If you are a scientific community, you just write this is the corpse angle, 47 is the corpse angle before my treatment, and after my treatment, the same patient with an MRI, the corpse angle is reduced to 35, means it is the scientific way of presenting how to treat a scoliosis. And it is very easy to take a photo of patient with scoliosis or without scoliosis. Photo back of the patient with the photo is not a way to present the prognosis of the scoliosis. If you are assessing the scoliosis, just mention the corpse angle before and after treatment, and you can give any ad, anything, any Facebook or WhatsApp, any account with the proof that before and after my corpse angle is reduced to this and this, and that means it is successful. It is the way how to present a scoliosis scientifically. It should be apart from a scientific community rather than just putting some photos or from X-rays. And I have seen so many doctors are treating disc-related disorder and they are putting before and after treatment. Before disc-related sciatica, before treatment accident. And it is very, very important that you can't see any disc-related pathology in X-ray. There will not be any changes in X-ray if it is a disc-related pathology. And even after fracture, the wedging will not be resolved even after any treatment. The wedging of the fracture will be as such even after 10 or 20 years of treatment. We can't change the alignment. We can't change the assessment. We can change the shape of the vertebrae after injury. If the patient is having a wedge fracture, even after years of treatment, years of exercise, the shape should be the similar as that of the injury. It is not resolving. It is always like that. And I have seen so many doctors are putting before and after, even though it is normal. And I have seen some patients with knee pain. They are before treatment, the knee gap is this much, and after treatment, the knee gap is this much. And it is very important that for OA-related treatment, the X-ray should be knee AP lateral with weight bearing. Okay, AP standing or weight bearing. And you can put initial X-ray with weight bearing if you are scientific. And after the treatment, if you are taking X-ray without weight or lying X-ray, normal AP lateral is in lying position. And standing means it is standing position with the full body weight. If you are taking initial X-ray in standing and after X-ray in laying, there will not be any gap. Initially, there will not be any gap, and after that, there will be a normal gap in the knee. It is not a scientific knee. You have to scientifically approach every cases. Okay. So this is the case. You can see Milwaukee shoulder brace and Boston brace. It is a Boston brace for mild disorders and Milwaukee brace for severe disorders. Okay. And you can see surgery, how you can do that surgery. It is very important. Cauda Equina syndrome and compressive myelopathy, if they are surgical, you can have, if they are clinically indicated, you can do surgery. You should refer the patient for surgery in Cauda Equina syndrome and compressive myelopathy. Even any patient with a spinal canal stenosis less than 5 mm, it is ideal to do surgery because it further may develop into Cauda Equina syndrome or quadriplegia or paraplegia. And sciatica with a foot drop. Sciatica with a foot drop, unilateral foot drop. It is very important. Sciatica with unilateral foot drop, you just refer the patient for surgery. If it is bilateral, sciatica with bilateral foot drop, it is related to neurology, that head-related pathology. It is very important. Sciatica with unilateral foot drop means it is disc-related and it should be treated surgically. If it is bilateral foot drop, a patient with a back pain, that means it may related to brain or spinal cord. Okay, and spine fracture with a distal neurovascular deficit or retropulsion, better to treat surgically. Okay, and scoliosis with a corpse angle greater than 40 and a kyphosis with an angle of 60 degree, it is surgical. All other cases which are clinically normal, that means without any neurovascular deficit, you can't treat with your conservative method. Okay, so the final conclusion is it is a science with a scientific background and never play with the dignity of our eternal science, that is Ayurveda. Thank you.
So it is such a illuminating, brain enriching, confident building presentation. Amazing, amazing, as expected. The only thing we were feeling guilty at 12:18, you had to gulp one shot of water. At 12:48, again, you had to gulp one shot of water. And I did put up in the Sitaram's official group that Shamir Bhai is going on with full sincerity. That is his magnanimity, but we feel guilty that, so we were very confused. Should we just say 1 minute halt? But the flow and the mood was so great for us and for you, and hopeful for the audience also, that we did not feel it appropriate to tell you to halt. And so let me confess that with a sense of guilt and gratitude. This is first thing. So it was absolutely great. You really have cautioned us, and I really feel grateful. And I'm nobody to appreciate you or anyone for that matter, but I feel really grateful that you were so point blank and so direct for the sake of dignity of Ayurveda science and its handlers, which we all are trying to be handlers, that you have made it so clear cut. And as we knew that it's your mentors from the allopathic sector who really gave you the confidence and the clarity, and that you also keep on learning even now. I remember you had sent me a selfie photo that you're still on duty. You are an established practitioner. You have your own set practice, everything. People come all over to you, but still your appetite for more and more experience and exposure is so unsatiable. You are never satisfied with your knowledge and experience. That makes you one of the most sought after faculty on this topic. Absolutely great. Dr. Rashmi, I think we have questions which can be taken care of. But before that, one Dr. Bora Madam, and the name Bora is a typical Assami title that I know. I don't know if ma'am is still here. If there is any way we could get contact of ma'am, Dr. Pallavi Bora Madam, Guwahati. Yeah, we have our people in Guwahati Ayurvedic College. Definitely. We have our friends in Assam. It would be so great. In fact, I had requested a couple of doctors there if we could have some faculties taking class from northeast of India. But I think we'll wait for the answers. But I think if we can get hold of the contact number, Dr. Rashmi, if you could, I don't know if you can track, if the IT team, Bintoji, can track based on this message, the contact, then let us proactively reach. She had already submitted her willingness to have presentation. That's so fantastic. It's so heartening to see that. So I hope she's listening. If not, let us try to reach out to her. So we start with the Q&A. There are 16. But Dr. Rashmi, I think in all due fairness, please do your part.
We are thrilled to announce about our new venture, the Gurukulam series under AACHAARA. The webinar series is to set the comments this month, offering an enriching experience with discussions, valuable takeaways. It features an exclusive 8-day Ayurveda tongue diagnosis workshop, an immersive online workshop with Vaidya Ramaprasad sir. Mark your calendar for November 20 to 23rd and 27 to 13th. Join us on this knowledge sharing journey. We will provide notes and recordings. The Gurukulam series will be conducted in both offline and online sessions in the future. Gurukulam series workshop can be registered through online with a token of payment. For any doubts, you can connect with us on 8129 42296. I repeat, 8129 42296. And your participation will contribute to the success of this webinar, and we look forward to instilling confidence in Vaidyas, helping them enhancing their ability to heal and become better clinicians. And also, I would like to announce next week we will have the session on clinical experience in Prameha by an expert clinician. We will discuss on the Ayurveda principles and importance of the lifestyle modifications. And this is an experienced clinician, which would be a very beneficial experience by the senior physician, Dr. J. Mannachan sir. He's a retired medical officer from ISM department and also a senior physician from Sitaram Ayurveda Specialty Hospital. Thank you. Sir, I think we can continue the Q&A session.
Yeah, I mean, you can do the product. Absolutely, it will suit the theme.
Sitaram Ayurveda having a wide range of classical products and both ethical patents. First, I would like to introduce some of our ethical patents. First is the SAP-Sayatin soft gel capsule. It's a powerful combination of Rasna Saptagam, Gugulu Tiktagam, fortified with Nirgundi Sarasamin, Enda Thailam base, which lubricates and nourishes degenerating disc and vertebrae, improves relaxation to reduce low back pain, and relaxes sciatic nerve compression. The stronger 1 gram capsule at affordable price. Very effective in lumbar spondylosis and sciatica. The dosage is 2 BID. SAP-Sayat soft gel capsule, the dependable support for lumbosacral pain. Next is the KG101 soft gel capsule, the time-tested anti-arthritic herbology, potentiated 101 times using milk in Tilathylam to provide strength and support to ailing joints. The immunomodulatory action of Guluji aids in managing rheumatoid arthritis and support in treating gouty arthritis. It's very effective in rheumatoid and degenerative arthritis. KG101 soft gel capsule, the ultimate remedy for rheumatoid arthritis from Sitaram Ayurveda. Next is a sapling plus liniment. The traditional anti-inflammatory properties of Chinchapatra cerasum, eucalyptus oil and lemongrass oil, powered by Pudina and Achamoja satam. The oil lubrication by penetrating deep into tissue and strong analgesic and anti-edema action. Fast absorbing anti-rheumatic and anti-arthritic ingredients providing quick relief. And it is quick acting in sprain, stiffness, frozen shoulder and back pain. It is very effective in muscular pain and joint inflammation. Usage is apply and massage gently. The sapling plus lemon, the quick relieving topical painkiller from Sitaram Ayurveda. Next is we are introducing our new product MG Leva Marma Guliga label based on the effective Marma Guliga Yogam from Sahasra Yogam. It is mainly indicated for traumatic joint injuries and swelling, and it is also effective in swelling in inflammatory and degenerative joint disorders. Next, we would like to introduce two our new products in Indugandha soft gel capsule and Tuggulu Tiktagagadam soft gel capsule. And we have conducted a comparative study of HPTLC of 5 gram of Grida with Avarti Grida. This Grida potentiated encapsulated in one capsule of one soft gel capsule and was compared based on HPTLC analysis. The following RF value shows almost similar area of the person in comparative study. And hence this proves one capsule of 1 gram is equivalent to 5 gram Grida. And also the same study was done for Gulutiktagadam soft gel capsule. And it also shows the efficacy of medicine. With just a small dose of medicine, required benefit is achieved. Next is the Yogamridam. This is a new venture for young doctors to know more about the special classical yoga, which covers the major ingredients, indication, and Rasaguna Veera Vibhaga of each drug, along with the clinical experience regarding that particular yoga from Sitaram Ayurveda Specialty Senior Most Faculties. Here you can see the clinical experience regarding Brihat Katpaladi Kashayam from Dr. J. Mannachan sir. He is a senior physician from Sitaram Ayurveda Specialty Hospital. And to receive the notes of Yogamridam in your WhatsApp, please send a text to 813-8888-932. I repeat, 813-8888-932. And to know more about Sitaram Ayurveda, please log on to our website www.sitaramayurveda.com. And also please note, we are sending e-certificates to all the participants who attend this webinar for more than 75 minutes. We are sending the notes and recordings to the email ID with the registered use for registration by the subsequent Saturday. If you could not find that mail in your inbox, please check your spam folder, promotion, social or career folder. And please save our email ID to your contact support at sitaramayurveda.com. And also please send your name, location to the following number of Sitaram Ayurveda to get all updates, links and notes of Acharya Rasayana via WhatsApp. 8943441881. I repeat, 8943441881. And for any support from Sitaram Ayurveda, please contact Mr. Rajiv. He's our Customer Relations Manager at 9072613194. And his mail ID is crm.osk@sitaramayurveda.biz. And that's the end of my presentation. Thank you all for the patient listen.
Dr. Ji, thank you very much. So now what we'll do is we will let the faculty himself to take up the questions, what he thinks should be answered. At least I think this revelation is very, very clear cut. I mean, many times more than what to treat, maybe it's better what not to treat. Maybe that is what we will have to learn first in the academy. There is more grace and more safety in what not to treat. And I'm glad Dr. Shamir has brought this to our attention very explicitly with his experience. And we will start with the questions. I think I would just leave it to you, Dr. Shamir. Please feel comfortable to pick up the questions so that we can save the time and we have more of your time than me, consuming the time, the common time.
Okay, Doctor.
Whatever you wish to answer.
Yeah, sir, I think the first question from Manoj Singh Baghel. What is the prognosis of spondylolisthesis and spondylolysis and how to approach? Okay, this is another subject actually. As the spondylolysis and the spondylolisthesis, these are the conditions which are actually not a traumatic. This is actually a developmental. And clinically, we can diagnose spondylolysis and listhesis. Usually, patient presented with a severe back pain and the radiating pain will be very less, especially low back located pain, especially with not usually radiating below the knee, but rarely it is radiating to lower limb. It is if it is high grade. Okay, and you can have X-ray, lumbar spine, APL lateral. Usually L4, L5S1 is the commonest area affected. And the X-ray will be usually L5S1, X-ray lumbosacral spine AP lateral. And this specific X-ray is there. The lateral view should be taken in flexion and in extension. It is very important that the lateral view should be in flexion and extension, so that you can clearly diagnose which stage of spondylolisthesis is there. Lysis is just breaking in the pars intra-articularis area, and the listhesis is when one vertebrae is displaced anteriorly or posteriorly. If it is a retrolisthesis, one vertebrae displaced over the another, it is called the spondylolisthesis. And the treatment approach is, it is very important that you have to use LS corset during the initial stage of the treatment and adopt flexion type exercise with the supine position. And it is ideal that if the patient is having clinical presentation, severe back pain, it may be type 1, it may be 25% anterior displacement. It is type 1. Up to 50, it is grade 2, and up to 75, it is grade 3, and up to 100, it is grade 4. Apart from the grading, if the patient is clinically lacking any neurological control, that means neurovascular deficit, severe foot drop or severe sciatica, if it is not treated after 6 months of your treatment, it is usually traction is contraindicated in spondylolysis or listhesis. We are giving mild traction to relieve the pain. So you can have 2.5 kg continuous traction for minimum 6 hours daily along with Snehapana. We are starting Google Tithagardhan Snehapana, and we are giving exercise along with if the pain subsides. So the prognosis depends on the presentation of the patient. It is ideal to go for surgery if the patient is above grade 3 or grade 4. That means above 75 to 100% displacement means there will be severe compression of the spinal cord. Especially it is called pseudo disc bulge. Disc bulge is not related to direct disc bulge, but it is due to the displacement of the vertebral body. So there will be a compression of the cord or compression of the nerve root due to displacement of due to uneven spinal canal. So if patient is presenting clinically, you can treat type 1, that means up to 25%, or type 2 listhesis. Up to type 3, you can treat successfully if it is clinically indicated. It is better to refer the patient, or it is better to treat the patient surgically if it is grade 4. If it is grade more than 75% anterior displacement. Okay, and it is very important that if the patient is having a previous history before 5 year or 6 year, again, if you are taking an X-ray and if you are comparing both X-ray, if it is stable there, even though if he is type 4, you can treat the patient conservatively. And that means the treatment depends on the presentation of the patient. If the patient is having severe presentation, severe neurological deficit or severe sciatica, if it affects the daily activities of patient, even though if it is type 1 or type 2, you can refer the patient. If a treatment fails after 6 months, even though it is type 1 and type 2. So the surgical, it is ideal to go for surgery if the patient is above grade 3, or means grade 4, it is surgical actually. But if it is stable before and after, you can treat even though it is grade 4. Okay. And spondylolysis is very easy. It is just a crack. Just to give a medication, never give any thyla. It is ideal to give Gugulithigdam, Gashayam and Labana and LS belt in the initial stage with exercise. You can treat spondylolysis. And it is better to review with X-ray in every year because you have to check whether it is displacing anteriorly or not. Okay. And another question from the same sir, Bagel sir. And what is the role of alkaline phosphatase in virus deformity? And the role of alkaline phosphatase not in virus deformity. Alkaline phosphatase has a wonderful role in bone related issues. Especially, it is very important that bone turnover, that mineralization and bone turnover of each and every area, it may be a spine or all area of the bodies, is determined by the alkaline phosphatase. It is actually an enzyme from the liver and it has work in liver and bone. This have a definite role in liver and bone. And I think you see that test GGT. If you are testing that liver function test, there will be GGT, not GTT, GGT. Gamma glutamyl transferase. This is the enzyme. If the GGT is normal and alkaline phosphate is elevated, that means it is related to an orthopedic pathology. Because in case of osteomalacia, in case of alkaline phosphatase, recase, elevated ALP is there. If along with ALP, if the GGT is normal, that means it is related to orthopedic pathology. If the alkaline phosphatase is elevated in an X-ray, in a blood investigation, that means it may be related to liver. And if the GGT is elevated along with the ALP, that is, it is not related to orthopedic pathology. It is related to gastrointestinal pathology. So it related to bone nutrition and bone turnover. Okay, if the value of ALP is more, that usually in children the value is below 250. And up to 600, 700, it is almost normal, even though normal value is 250. But if it is above 700 or 600, that means it is pathological. So you have to differentiate along with other investigation like liver function test, etc. Okay. And another question from the same sir, what is a frog leg view? So it is ideal to do frog leg view because in case of hip pathology, the ideal X-ray is pelvis with both hip AP. It is a normal X-ray in all age. But in case of children, it is very important that you have to take frog leg. As in frog leg, it is the picture of hip with the abducted position. So it is very important that to rule out that Perthes disease, because you see in session between the age of 4 to 8, you can see Perthes disease. And you can see that abnormal, that is slipped capital femoral epiphysis, and you can see the avian. So in case of children, usually below the age of 15 or 20, it is ideal to do that frog leg because in case of, for example, in case of Perthes disease, there is shrinking of the head of the femur. So you can see there will be a gap between the joint space and the head. So it is a diagnostic criteria for that Perthes disease. So any abnormal joint space between the head of the femur and the acetabulum, it is a diagnostic criteria for Perthes disease. So for assessing the joint space, for assessing the head of the femur in children, along with pelvis with both hip AP, the frog view is the best option. Okay. Next question. Yeah, osteoporosis vertebrae or back pain management. And it is from Dr. Abhijit. What is osteoporosis means? It is very clear that if your patient is having osteoporosis, in X-ray you can see how osteoporosis can be diagnosed. Simply a patient with age, usually more than 55 to 65, you can see osteoporosis. And clinically, you can see in radiologically in X-ray, the upper border and the lower border of the vertebrae is having a concavity. It is called biconcave deformity or fish vertebrae or fish mouth appearance. And in MRI also, you can see there is an increased intervertebral height in MRI. Usually, radiologists are not describing the osteoporosis, but you can see in the film that the intervertebral disc height is elevated in osteoporosis. This is due to the concavity of upper and lower vertebrae. So it is called biconcave deformity or that fish mouth appearance or fish vertebrae. And the treatment is very important that never go for any traction, never go for any manipulations, never go for any Rushada treatment. You can directly treat the patient with a simple exercise like yoga. Never go for any manipulation. You can treat direct Brahmana therapy. Especially you can start Thaila therapy. But never ask the patient, even though patient is having radiating pain or clinical presentation, never advise a patient to go for a rest. In osteoporosis, rest is contraindicated, traction is contraindicated, and lumbar corset or belt are contraindicated. Mild stretching exercise is indicated. And it is very clear that blood picture is not a test for osteoporosis. If you are taking a blood picture of the patient with osteoporosis, calcium will be normal, ALP will be normal, and in osteoporosis, the BMD is affected, bone mineral density is affected. But in case of rickets and osteomalacia, vitamin B3 and calcium will be deficient. So the treatment should be Brahmana and never go for any mobilization, never go for any manipulation. You can have mild stretching exercise along with the drugs should be pitta predominant. Sorry, that Shiragrade, Tikta Samyukta Vastibistara, like strengthening the bone and joint. The treatment should be like Gandha more than Gandha capsule, ideal to use Gandha itself along with milk. And Guglitagradan, Gandha is the ideal option for osteoporosis, osteopenia, osteomalacia, and rickets. And the Shilpa Pandey, can you Ayurveda meniscus stage, spinal canal stenosis? Definitely, Dr. Shipra Pandey, you can treat spinal canal stenosis. You can clinically diagnose spinal canal stenosis with neurogenic claudication, that is presenting severe pain on standing or prolonged walking, and there will be sudden relief on flexing the spine or on sitting. So you can have an MRI. It is ideal, whether it is caused by any spinal canal, that is any osteophyte formation. If it is due to facet joint arthropathy or it is due to multiple osteophytes, it is better to go for surgery because it is a mechanical pressure. But if it is due to ligamental flava hypertrophy or if it is due to that severe posterior disc bulge or posterocentral disc bulge, you can treat the disc bulge initially so that there will be no spinal canal stenosis. Because if you are relieving the pressure over the spinal canal by a posterior or posterior central disc bulge, you can treat the spinal canal stenosis. And it is ideal if it is disc-related pathology, Nimbamradadi, Arandam, along with Mahamanjishtadi and Rasaayandadi is the ideal option. If it is stenosis due to that ligamentum flavum hypertrophy or posterior longitudinal ligament buckling, better to start with Varanadipta Mahamanjishtadi and this Aranda preparation. And Aranda Snehapanam is the ideal option for all spine-related pathology. It is my opinion, not generalized. What should chiropractic correcting scoliosis, any complication for the patient later on? It is very important because of the lack of time, because scoliosis is the area we have to discuss minimum half day, because the scoliosis is a structural scoliosis start in the very beginning, because the scoliosis below the age of 3, the treatment is entirely different. Okay, it is a congenital one. If you have a congenital deformity, you have to treat the patient with the MRI. There may be possible respiratory distress or other visceral issues. Okay, and usually it will resolve by itself. Okay, and if it is not resolved after 2 years, it is very important. If the scoliosis in the congenital scoliosis not resolved after 2 years, go for surgery from the 2 year itself. It is very important. Otherwise, it is life threatening. And after 3 up to 7, it is entirely different. Usually in that age, ladies are affected, girls are mostly affected, and dorsal scoliosis is the most area, which is usually right-sided scoliosis. Okay, so there are so many areas. If it is left-sided scoliosis, for example, if the patient, she is just 9 or 10 years with a left-sided thoracic scoliosis, if you are doing a manipulating with the chiropractic is not a structural correction. Chiropractic is not for structural correction. If the patient is having a scoliosis, you can correct the scoliosis by releasing the muscle. Up to an extent, if the patient with a scoliosis, up to an extent you can correct with the scoliosis. It is not a structural correction. It is correction by the muscle tightness. They are correcting the just muscle tightness, because if a patient with the scoliosis, left-sided thoracic scoliosis, there will be severe compression of the chest. Okay, there will be cardiac-related issues in left-sided scoliosis. Is very rare. If you are doing any manipulation, there will be sudden collapse of the patient. So manipulations, especially chiropractic manipulations, are indicated to release the muscle, not to release the structures, because they are so dangerous. And in later stage, in a lumbar area, usually their left-sided scoliosis are very common, especially in adult male. If it is thoracic, usually right-sided thoracic scoliosis is more. If it is kyphoscoliosis, never go for that manipulations, because it will break the vertebral body. So there are so many complications if you are doing chiropractic in spinal disorders, especially in that scoliosis. So you should be conscious. You can do chiropractic just to release the muscle, just to correct the muscle tightness, not to correct the vertebral alignment. Okay, it is unscientific, and you cannot do any any bone correction with chiropractic, because I know chiropractic. I have trained chiropractic, but I am not doing chiropractic. I know where to do and where not to do. Okay, and sir, can we measure corpse angle from the X-ray? Yeah, sure. Definitely, you can have videos or YouTube. You can see how to measure. You can measure corpse angle. You just check the lowermost deviated vertebrae and uppermost deviated vertebrae, and on the lower border you can have a line, and the line intersecting it will form the corpse angle. You can see the video. You can see available in the YouTube. Okay, you can measure from your X-ray itself. Then Dr. Arshia Sheikh. Can we advise MRI CT if patient is having stent in the heart? Doctor, it is the basics of when to prescribe, where to prescribe. Actually, no, it is not possible. You cannot do any MRI. If a patient is having a stent, you can have CT. You can't do any MRI because MRI is contraindicated if the patient is having stent, if the patient is having aneurysm clips, if the patient is having that cochlear implant. So these are the basic contraindications for MRI. Cochlear implant, aneurysm clip, and that stents are contraindicated for MRI. Instead, you can have MR myelogram. Sorry, CT myelogram, not MR myelogram. You can have CT myelogram if the patients are contraindicated for MRI. Okay. Then the next question, Erb's palsy. Erb's palsy, how you can manage Erb's palsy? It is very important how to diagnose. It is otherwise called policeman tip hand. Surya,
Sir, the question is exactly when to choose between MRI and CT scan in spinal joints pathology.
Okay. So in spinal pathology, it is very important that the MRI is more functional and the CT is more structural. So if the patient is having a fracture or abnormal growth, so to assess the extent of the growth, to assess the structural deformity, ideal choice is the CT scan. If the patient is having a head injury, Okay, first or a spinal injury or a fracture, go for an X-ray. If then abnormality in the X-ray, for structural assessment, for surgical correction, better to go for a CT scan. It is functional, so it is structural actually. Or if a patient is having a burst fracture, after CT scan, you can see what is the actual condition of the spinal canal. So after surgery, you can have an MRI if the patient is having neurological defect like paraplegia or quadriplegia or foot rope. For assessing the functional aspect, it is ideal to go for an MRI. For structural correction, for surgical correction, for structural assessment, CT scan is the ideal option. Can we effectively treat the disc desiccation through Ayurveda? Dr. Rega, the term disc desiccation is, it will start after the age of 20. Everyone have disc desiccation, depends on the body weight and the strength of the abdomen and back muscle, and depends on the daily routine activities. If you are sitting for a long time without any regular exercise and diet, with obesity, definitely you have disc desiccation. Disc desiccation means there is a lack of proper nutrition to the vertebral end plate. So discs are the most avascular structure in the body. So the nutrition to every disc is through that vertebral end plate. So due to lack of proper exercise, lack of proper rest, due to obesity and exercises, it may develop disc desiccation. So this is the pathology. If you are reverting the pathology with a proper exercise, proper strengthening exercise, controlling your body weight, along with that snehapana, like that gridapana, that mahatiktaga or gurutam or thaila snehapana, you can revert the disc desiccation, no doubt, if you are young enough. Okay, above the age of 40 to 45, it is very difficult to revert the disc desiccation, but it is very easy, even though the patient is, I have seen the patient, he is 83. Okay, he is regularly doing that badminton for 2 hours. One of my patients, he is 63. He is the first person in a marathon conducted by our area. More than 500 participants. He got first prize. He is 63. So it depends on the fitness, obesity, central obesity especially, and the muscle strength. You can revert the disc desiccation. If you are not reverting the disc desiccation, it gradually leads to that disc bulge, etc. All IP Ayurvedic treatment to be avoided in the annular tear cases. Kindly share your experience treating same. And just annular tear, it is actually not a complicated one. Annular tear means there is inner nucleus and outer annulus. The annulus is having 3 layers, and the inner 3 layer is nociceptive, having no pain receptors, and the just outer layer is having pain receptors. So just annular tear means it is actually a normal one, normal disc bulge. So it is ideal to control the body weight, ideal give that extension exercise, back muscle strengthening. Along with that, your treatment just have, I think it is not better to do any IP treatment. With even OP level treatment, you can treat that annular tear. Annular tear is just a normal terminology actually. If it is clinically important, only if it is extrusion and sequestration. Because extrusion and sequestration is complete tear of the annulus, and the disc material is come out. So the pressure inside the disc is reduced, and the remaining area in the spinal cord and the nerve root. So back pain is reduced and the radiating pain is more. So you can treat any cases of annular tear, no doubt, with OP level treatment. No IP is needed actually. Next one, exactly when to choose, Dr. Surya, between MRI, CT scan in spine and joint pathology. I already explained, I think. In case of other joint pathology, if it's a long bone fracture, like a humerus fracture, in case of intra-articular fracture, like a knee fracture or a hip fracture, so large joint fractures and long bone fracture, it is ideal to do CT scan. Because in case of humerus fracture, there is a possible wrist drop due to radial nerve involvement. In case of a femur fracture, lower femur or upper fibular head fracture, there is possible foot drop. So in case of a long bone fracture and in case of spine fracture and in large joint fractures, ideal option is CT scan. In case of a rotator cuff tear or that ACL or ligament tear or meniscal tear or muscle tear, the ideal option is MRI. Then avascular necrosis, which stage we have to refer the patient? Bagel sir, again, avascular necrosis, it is very difficult. As the name indicated, it is avascular necrosis. That means there is no vascularity, If there is no vascularity, it means that structure become dead tissue. So in case of hip, it is very difficult to diagnose avascular necrosis in the initial stage. And in X-ray, I have patient with avascular necrosis, but usually I am not treating them because X-ray visible avascular necrosis is usually the third stage. And third and fourth stage are always 100% dialogue, because in third stage itself, it start necrotizing the femoral head or that specific area. So in case of AV and hip, it is ideal to refer if it is visible in X-ray, because X-ray visible necrosis, that means it is a third stage. If it is in initial stage, stage 1 and stage 2, you can try your treatment. If your treatment fail after 6 months, it is ideal to do hemiarthroplasty. Sorry, not hemiarthroplasty. In AV and hip, the complication is OA hip. So it is better to do that total hip replacement. Okay, so in case of initial AVN, they will do hemiarthroplasty or other treatment. But if you are treating the AVN, even though the prognosis is bad, it leads to OA hip, and the further treatment is total hip replacement. It is much difficult situation. If it is hemiarthroplasty, he can continue his all regular activities. If it is a total hip replacement, there means some limitation for their regular activity. So it is ideal to, it is X-ray visible means it is more than 3 grade. So if it is X-ray visible, if it is more than 3 or 4, it is ideal to go for a surgery. Osteoporosis, vertebral and back pain management. What are the care should be taken while treating ankylosing spondylitis, both in normal spine, not fused spine, and fused by spine, bamboo spine, acute or chronic case management? Actually, there not be any acute or chronic case in ankylosing spondylitis, because ankylosing spondylitis is a zero negative spondyloarthropathy. The blood pictures are almost normal, and the patient presented with a chronic sacroiliitis initially, and it gradually developed into pain and stiffness in the upper back and then into lower back. And the late stage only, it is very important that in the late stage only, they will present as a bamboo spine. If it is bamboo spine means you can't treat that patient. And it is very important clinically, never treat the patient with the thyla. No thyla prayoga in ankylosing spondylitis, and no rest in ankylosing spondylitis. Treat as Vada Rakta Chikitsa and start yoga and start regular stretching exercise. Because I have a patient with severe ankylosing spondylitis of neck. He is still continuing his regular job. Never do any thyla prayoga. It is very important. Never go for any traction, etc. Okay, never go for any rest. It is very important. Rest is contraindicated and thyla prayoga is contraindicated. And typical exercise, regular exercises and stretching exercises are indicated, and Vada Rakta Chikitsa is the ideal option. Okay, and they're not acute or chronic management. It is always chronic. That can we treat facet joint? That Dr. Abhinav, can we manage facet joint arthropathy? Definitely, we can manage facet joint arthropathy, because what is facet? Among the spinal canal, there are only one area it is having a synovial joint. Okay, because in disc vertebra it is having intervertebral disc, and there is facet joint. It is actually not fully a synovial joint. It is a zygoapophyseal joint. It is a zygoapophyseal joint. That means it is a partial synovial joint. So any osteoarthritis or any inflammatory arthritis or any RA-like inflammatory arthritis may affect the joint pathology. If it is a facet joint arthropathy, clinical presentations are entirely different. Patient is having better inflection. Usually in facet, that discogenic pain will be better in extension. But in case of facet joint arthropathy, patient will be better in extension. It is very important. So if you are using that pillow, patient will be better. If you are using a cervical collar, pain will be more. So like inflammatory pain, patients feel better in supine position. And there will be tenderness on either side of the spinous process, and neck extension or back extension, patient will be having severe pain, and there will be better inflection. It is very important patient feel better inflection, and pain will be aggravated in extension. So you can treat this facet joint arthropathy when it is diagnosed same as that of osteoarthritis. You can start with inflammatory like Rasa Saptakam Kashayam, etc. If it is subsided, you can directly go for Varnadi Kashaya and Kaishora Gugulu, etc. Never use any thaila. It is very important in case of acid arthropathy. Never use any thaila. Better to use that labana like churna. Okay. Then how to that Ebb's palsy? Okay, you just Ebb's palsy is you can see that lower area of a spinal cord, especially C5, C6, C8, C5, C6, C7, C8, and T1. These are the area of Ebb's palsy, and it is clinically very. It is otherwise called polysmantic hand, and it is very important that in the initial stage, even after just after birth, we can notice the Ebb's palsy, and it is very important that the muscles that which are affected is deltoid muscle is affected, and infraspinatus and teres minor and brachioradialis and deltoid. These are the muscles usually affected. So it is ideal to tie the patient in this position. You tie the patient's hand in this position in the initial stage of the treatment itself. From the second or third day of the treatment, start with two, because the condition is polysmantic hand. The elbow is that the shoulder is abducted, shoulder is adducted with internally rotated. So to prevent the contracture of the to prevent the contracture of the subscapularis, it is the most important complication of Ebb's palsy. To prevent the contraction of the subscapularis, better to do our massaging treatment. It is ideal, and always keep abduction and external rotation, or tie the patient from the very next day of the birth. Tie the patient during the rest in this position, or keep always this position to prevent the contracture of the Ebb's palsy, and start our treatment along with the physio. So on physio should be noted that this position is the ideal area, ideal way to prevent the contraction of the Ebb's palsy. So there are so many medicine, but medicine rather than medicine, the physio is most ideal option. Sir, Pintus Vedas are advisable in disc herniation, spondylolisthesis. Yes, doctor. Pintus Vedas, all the Vedas are advisable in herniation and spondylolisthesis. No precaution, because if you are clinically treating patient, if you are assessing the neuromuscular deficit, if it is treatable, you can treat every treatment. No partial treatment. If you are treatable by Ayurveda, you can do anything. The contraindications are usually not our treatment. The contraindications are the activities from the therapist. They are doing their massaging or breaking. You can do any treatment. You can do Vasti, you can do Sweda if it is clinically indicated. If it is not indicated, it is surgical. So it is better to you always better to advise, better to educate your therapist while doing treatment in herniation or under spondylolisthesis. Okay, always use belt up to that treatment area. After that, you have to. If it is grade 4, in grade 1, grade 2, it is not a relevant one. Any other doubt, sir? Sri sir, any doubt? Any other? And TMJ joint disorders and our management. Actually, the TMJ temporomandibular joint. Usually, if it is a post-traumatic, there will be a rupture of the ligament. Okay, so it is actually treatable, but it is very difficult to treat at post-traumatic TMJ injury. And normally, we are using that Karutam Marmani leba for external application and taking an X-ray of mandible lateral view, skull lateral view. Usually, the TMJ is based on TMJ pains are basically from the arthritis, TMJ joint arthritis. So you can treat it like arthritis, and it is advisable not to use heavy chewing during the treatment. And you can take, I have 2 or more patients who share regularly. They are doing their daily activities without any problem, even though, and she was a young lady now, she got married. But it is very important not to use heavy chewing. It is very important during the treatment, and it is better to give that ballooning or chewing a symbol and every day to strengthen your masseter muscle. And you have to use that external application, not thaila, but Karta Marmani leba or Marmavat for regular use. And you can treat TMJ. But if it is a chronic one, it is very difficult. There are so many questions which is not related to spine. Meniscus tear prognosis, arthroscopic meniscectomy.
I would suggest, sorry to interrupt you, that it's best to only involve with the questions of today's topic so that we respect those who put up those questions.
Yeah, there are so many questions outside the topic. like knee injury, arthroscopy, hemarthrosis.
That can be conveniently and respectfully, actually, conveniently and respectfully, it can be avoided. Absolutely fine. We are not breaking any rules. We are not being disrespectful. We are just being respectful to those who have shown the topic specific questions. And the very fact that people are still 100 plus in spite of nearly 1 o'clock is, I mean, that just unbelievable. I think this is one of the most extensively benefited webinar on any
2
topic.
o'clock, sir, not 1 o'clock.
Yeah. I mean, no, 104 about 3.5 hours is absolutely, I mean, people won't stay that long even for a cinema non-stop. So this is absolutely great hit already. What I would suggest is, please, you decide which you want to answer or you don't want to, and then we will stop.
Sir, almost questions are over, and they can send me through WhatsApp. I will answer today.
Yes, absolutely. You have already stressed so much of yourself. You have stressed yourself so much, and as I would say always in every group, as I normally do, you are such a blessing to all of us. Your help is so spontaneous and so thorough and so authentic, and you really help us from not getting into for pitfalls. And that's what it is. No, that is really the word guru applies to you in terms of experience, in terms of the nurturing, mentoring, guidance. The list is long. And I always tell, Shamir Bhai is a great blessing for our community and for us personally too. Absolutely. Dr. Rashmiji, Ramanan sir is with us now?
No, sir.
Okay. Then I think you or me, we can call it a day. And that is fantastic because the email address has been shared already. And so has been the phone number. And what I've done, Dr. Pallavi Bora madam has been contacted by WhatsApp. I don't know if ma'am is here. If somebody known to her is here, Dr. Jyotirmay Sharma of Guwahati Ayurvedic College, Professor H.O.D. Shalakia, a dear friend of us, he has gave her WhatsApp number, message has been sent, and the same has been brought to the notice of Sitaram license unit. And she has shown the interest, very kind of her, very great of her to show the interest to bless her with her teachings. So I think the next opening that comes up is February 1st week. Because we make sure the calendar is ready for the next 3 months. I personally ensure our team, Dr. Vignesh, Dr. Rahul, Dr. Ami, and me, 4 of us, we ensure that we keep the calendar ready for the next 3 to 4 months. So I think February 1st Sunday would be, if convenient to her. I hope she listens to this or somebody known to her listens to this. And of course, we'll call her also. Absolutely illuminating, eye-opening, and confidence building, and full of caution webinar, full of caution, full of red signs and red flags to be taken care of. And I think we must invite Dr. Shamir after 5 or 6 months, at least twice a year, if he would bless our webinar. That will be.
This is the third one, actually, in Sitaram.
No, more the merrier. I would use the word more the merrier. So that is fantastic. Thank you all. Being a Diwali, being with us, more than 264 of you. Itself is very impressive. It's a sign of progress. Desh ka hit ho, desh ka jeet ho, and that's the best way is through Vaidyas and the community of patients being treated well. So, Dr. Rashmi, if you wish to conclude, yes, ma'am, it's all yours.
Yes, it was really a learning experience. We appreciate the effort and expertise you brought to the session. Thank you, sir. On behalf of Sitaram Research Foundation and Sitaram Ayurveda Pharmacy Private Limited, once again, thank you, sir, for your dedication to spreading knowledge and time with us. And thank you, Srijit, sir, and all our dear participants. Thank you all, and happy Diwali